Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is April 9th. It is time for a regularly scheduled IC support group meeting. The purpose of these meetings is to make you so strong, so knowledgeable, so incredibly informed that no one can ever mess with you again. Hello, Sherry. Hi, Barbara. How are you ladies doing this fine Sunday afternoon? The woman of the thank you. The woman of the hour with a swollen lip. And it's cloudy outside and the lights are not right and I cannot get anything right here. Hello, Lauren. Hi, Kata. Let me see if I'm changing. Does that help? I don't know. It's so weird when it's all cloudy outside. I don't get the light that I need to do these support group meetings. And then it gets all, that might be a little bit better. There you go. Oh, what a week, what a week, what a week, my friends. What a week it has been. What a life we are living. It is absolutely crazy right now. The stress level is real. Okay, like seriously, can we get this right? How are you feeling today? Hi, Tabitha. Hi, Sherry. All right, I'm just trying to get my computer set up here correctly here. You can see I'm moving windows around. There we go. Okay, I don't know why this side of my face is dark. I apologize. Is that better? Okay. My main light started malfunctioning, so I had to turn it off. Okay, let's just try one more thing here. Would it help if we're just a wee bit brighter? Yeah. All right, I can live with that. I can live with that. Yeah, okay. Hello, Grace. All right. This is our regularly scheduled IC support group meeting. We use a month. If you're wondering what is wrong with my face, it's because my lip is swollen right there. I should have an ice pack on it, but it's a pimple. Yes, you do get pimples when you get older. Life, right? Hi, DJ. DJ, thank you for the 100 stars. I really appreciate it. Hello, Jennifer. Hi, Christy. What do you know about, Christy says, what do you know about using low dose naltrexone for IC? I believe I did an article on it in our fall magazine. Hold on. Didn't get sleep last night. I don't know about you guys, but seriously, I am having trouble going to sleep at night. I am way back. There's a sleep schedule you get when you have pain. And for me, when my IC started, the nights were absolutely the worst. So I got to the point where I didn't like going to sleep at night. And as many patients notice that you go to bed later and later and later and later, and part of it is just kind of fear of sleeping because sometimes when you have IC, your nights are your worst. And so I did that for, like the first 5 or 6 years of my IC, where literally I was going to bed at 2 a.m. And then I got better and I got a normal sleep schedule again for like 15 years. And then we had the fires. And there you go. I had to be up at night in case we had a evacuation notice. And I'm all messed up again sleep-wise. I went to bed last night at 3:30. And I was looking for my article on low-dose naltrexone, and I cannot find it. You know what? Off the top of my head, honestly, I don't remember what I wrote. I think, let me just refresh my memory here. I don't want to give you wrong information. I know that we did a really big interview about it. but I didn't write the story. Stacy, our writer, wrote the story, which is why. So it's a novel anti-inflammatory agent in the central nervous system via action on the microglial cells. The effects are unique to low doses of naltrexone and appear to be entirely independent of naltrexone's better-known activity on opioid receptors as a daily or oral therapy. LDN is inexpensive and well-tolerated. It's considered highly experimental. Published trials have low sample size. I'm just looking for, I want to give you, so hold on a sec. There was a time when I could have wrote all of the research studies. I can't do it anymore. There's so many. And naltrexone is fairly new. We don't have any major IC studies on it. The National Institutes of Health has not done a study on it. I will tell you honestly, I don't think I've talked with a single patient who's used it successfully, but that doesn't mean that it's not a viable option for you. The question as we consider novel off-label therapies is do no harm. Is there any chance that it's harmful? If it's harmful, you need to have a really good discussion with your doctor. So Christy, getting back to your question, I don't think that I have personally talked with anybody who has benefited from LDN, or if I have, maybe one in the last 5 years. So I don't have any raving positive success stories about it, but that doesn't mean that it's not viable. As a support group leader, here's the deal. My deepest fear for 27 years as a national IC support group leader is that I could turn you off from the one therapy that really might help you. And that is not my intention. I don't ever, ever, ever want to do that. Ever, ever, ever. And off-label use of medications is real. I mean, most of the therapies listed in the AUA treatment guidelines for IC are off-label therapies. And so if your doctor believes that it could be viable for you, if you have looked at the potential side concern you, if you have talked with other patients who have your subtype, because remember, it's all about subtyping. And so if you have talked with other patients who have potentially found it helpful, but you've done your due diligence and you've talked with patients who have had a bad issue with it, as well as patients who have bad benefit from it, if you're walking into this fully informed and you've got your doctor's approval, I say it's viable. But again, off the top of my head, I don't believe that I've talked with anybody recently who had success with LDN. I might have had an email or two. You know what? Hold on. Let me just check my email here real quick too. Mm. So in 2018, I got an email from one patient about it. And they were just asking for information and they hadn't used it. And she said that she'd specifically decided not to do that. And then last year I had somebody asking for information about low-dose naltrexone. And I know we did an article on it. I just didn't write the article. All right. Hey, I also want to say I was cruising through Facebook a little bit. It's a little bit earlier today than normal, which is pretty good since I went to sleep at 3:30. And there was somebody on one of the Facebook forums asking if what people's opinions were on Cipro. And guys, we had a major alert from the FDA about Cipro last year. that Cipro is no longer meant to be used for simple urinary tract infections. Why? Because the harm outweighs the potential benefits. Cipro is associated with very serious adverse effects now, from um, tendon rupture to, at its worst, aortic aneurysm. But even they call it something called being floxed, FLOXED, floxed. And there's a group of patients, young patients, completely healthy, who have taken Cipro, and they end up ill for years and years and years, and they call it being floxed, where the medication does some critical damage. And so, you got to be careful when you're asking for information on Facebook, because you got to start with the facts. I have a blog on our website, Have You Been Floxed? It includes the FDA warning about um, Levaquin and Cipro as treatments. All right. And again, guys, I'm operating on a little sleep, so I might not be here all the way. I'm 90% here instead of 100% here. Melanie says, recently diagnosed with candida. All supplements are filling my bladder. They told me to take Candex enzymes and grapefruit. Oh, Candex, comma, enzymes, comma, and grapefruit seed extract. You know, Candex, I had a warning about Candex. God, what is this today? But I don't want to be all doom and gloom today, but the last thing we want are bad reviews. No, no, no. Okay, so that's not true. So let me look at that real quick. Candex is an ultra potent, 100% natural proprietary blend of enzymes that break down the candida cell wall. Mm. Few dietary restrictions, fast results, no die off, money back guarantee. 4.5 stars. I don't Okay, so that isn't what I was thinking it was. Normally with candida, Melanie, here's the reality. The National Institutes of Health have clearly associated candida with flares. We now know from our own nationally funded research studies through the MAP Research Network that many IC patients struggling with flares have an overgrowth of candida in their urine. And this makes sense for two reasons. Because if there's any group of patients who have been massively overexposed to antibiotics, it's going to be us, because most of us have been prescribed lots and lots of antibiotics when we were newly diagnosed, under the mistaken assumption that we had urinary tract infection. And then also, when we look at the IC diet, unfortunately, the IC diet is fairly high in carbs. Candida love carbs. And so we are definitely more at risk for candida. And of course, typical urine testing does not test for fungus like candida. And so many of you will have flares. You think you have UTI, your routine urinalysis comes back negative, and bam, you have no clue that you have a fungal infection. At our last meeting, I also read yet another new study from the National Institutes of Health, which was able to associate that not only did we have candida, we had a lot of different fungus in our urine, and that more pain was associated with higher fungus, higher species of fungus. The more diverse uh, species of fungus in our urine was associated with more severe pain. And so, rule number one here, guys, is you don't take antibiotics unnecessarily, because the number one risk factor for the growth of fungus in our urine is going to be inappropriate antibiotic use. But the second thing you got to remember, especially with candida, is candida feed on sugar. And so, Melanie, there are a couple of really good books, The Yeast Connection and The Yeast Connection of Women, which talk about modifying your diet. I had a super drug resistant Candida labrata infection about 10 years ago, 15 years ago, that I had for 2 years. Holy hell. And and you know what? It was longer than 15 years ago. Actually, it was, because I was doing the Fukushima protocol for IC at the time, which back then was associated inappropriately with antibiotic use. So I did Augmentin for 3 months, grew this really resistant, candida infection. And that was combined with the fact that I was sitting on a hot, chair cushion. I liked heat. Heat felt good, and my friend Diane, who helped me start the IC network, gave me a heated seating, a heated chair cushion for my, work desk here. And so not only was I taking antibiotics, I was sitting on a hot cushion, and I grew a wicked a wicked candida infection right on my vulva. Um The yeast connection helped me tremendously because what I could clearly see is every time I ate sugar, the yeast flourished. Every time I ate ice cream, I had a flare. Absolutely, because that yeast was growing and prospering. You know, whenever you make yeast bread, what do? You prepare the yeast with a warm water and sugar, and then the yeast bubbles. I made homemade cinnamon bread, yeast bread last week, and that's what happens. Well, that same thing happens in your body. When you eat a lot of sugar or carbs and you've got an overgrowth of candida, it grows. I don't have any experience with Candex. I was thinking that that was something else that it wasn't. That also ends with an X. Um, Grapefruit seed extract, I don't think would bother your bladder too much. The enzymes, Candex's enzymes, I'm worth a shot. When I looked at the website, it did say that there were some side effects. I would be curious to see what the side effects were. But again, I don't have any experience with anybody using that. I'd be very interested in hearing your experience with it. All right, Kieran down on YouTube says, I've used LDN for the past year and felt it was helpful in helping both my chronic pelvic and sciatica pain. No side effects. Awesome. Thank you for letting me know. Anybody else take low dose naltrexone? Do you have any experience with it? Hello, DJ. Welcome to the IC Network. Hello, Jennifer. Very nice to see you too. Hi, Megan. Nice to see you guys. I really should introduce myself. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States at 27 years and counting. I bring with my history as a support group leader 3 college degrees. I have a degree in chemistry, I have a degree in pharmacology, drug development, including a 1 year surgical internship. I have a master's degree in psychology. I could not finish my PhD in psychology because I could not sit in a car and drive to school because of my IC. The IC Network was my doctoral dissertation proposal on how to bring support to patients who were homebound. And I'm very delighted that 27 years later, the IC Network remains the #1 website rated on IC by Harvard Medical School and the University of London in 2 peer reviewed research studies. And I think one of the reasons why we're successful is because #1, I have a fantastic team of volunteers who help us. I have guys, I had a doctor say to me, and I've told this story before. Um, so my bladder pain hit when I was 33 years old, and I could barely walk the first year. I had the equivalent of a chemotherapy burn in my bladder. I had a chemical burn in my bladder. And I was drinking a quart of cranberry juice a day for a year, not having a clue that that was actually making it that much worse. And at the end of that year, I I I could barely walk. I was at the emergency room all the time. I was sleeping or trying to sleep on my living room floor every night. I didn't want people to hear me going to the bathroom. I was going to the bathroom all of the time. And I had a doctor say to me at the emergency room one day, you will forever be a burden on your family. This is your life. You will always live with this pain. You better get used to it. And as appalling as that was, it woke me up because I went, wait a second. Wait a second. I have 3 college degrees. I have an award from the White House. I was a presidential fellow when I was in graduate school. I will prove you wrong, you son of a bitch. How dare you say that to me? I am not going to become a burden on my family. And a month or 2 later, I started my first support group from my bed. I see Redwood Empire in Northern California. Within 6 months, it was one of the biggest support groups in the United States. I had 300 people in my group within 6 months. But I got very, very interested in patients who were homebound because I had been homebound. I would drive to my support group meetings 20 miles away crying because the pain it hurts so freaking bad driving in the car. I'm in Santa Rosa. I would drive down to Petaluma, and I'd put all this time into preparing these support group meetings, and 300 people in the group. You would think at least 100 people would come to a meeting. Well, I was getting 30, and I would call people afterwards and go, "Why didn't you come to the meeting? I had stuff for you." And their answer was always, "Jill, it hurt." And the thing is I could totally relate to that because I was crying getting there. I was a wreck driving there. I mean, it was a real test of my character. And that's really what struck me is how could I bring support to somebody who was homebound? I found a dissertation at Stanford University on Narcotics Anonymous online support, and I applied that to interstitial cystitis, and the rest is history. And that's exactly what the IC network is. We are the largest support group in the world. We have well over 35,000 members. We work with about 100,000 patients a month. And I decided that, I kind of miss being, let's see, how do I want to say this? How do I want to say this? I started having a love-hate relationship with social networking, especially Facebook, because when I would come on Facebook, I would find information that truly frightened me. And I shut off the IC network for a while on Facebook, and then we had to do a clinical trial recruitment. I turned it back on, and then just one day it just kind of dawned on me, Jill, wait a second, what do you think would be helpful on Facebook? And I just said, let's do real support group meetings. I sat on the U.S. Army IC research panel for a decade. I know my stuff. I read IC every day. And so my job here is to empower you. My job here is to give you real life information. I want to show you fad versus fact, if I can. One of the fads that we faced with years ago was silver nitrate. Many people said, "Hey, if you use silver nitrate, that will cure your IC." And we had people actually drinking silver nitrate. It was crazy, or putting silver nitrate on their eyes. They would come to my support group doing that. It's like, what the hell are you doing? Stop it. There's absolutely no proof that silver nitrate is helpful for IC. We had people who would come in and say that their supplements would cure IC, or that magnets would cure IC. And the word cure is so inappropriate in this circumstance because guess what, my friends? We don't think of IC as an incurable bladder disease anymore. We don't, and we haven't for a decade. IC is, in essence, a pelvic pain syndrome, or a urologic chronic pelvic pain syndrome. That actually is the official name for IC research with the National Institutes of Health, urologic chronic pelvic pain syndrome. Why? Because there are structures outside of the bladder also involved in almost every single patient. And so now we understand very, very, very clearly that the IC patient population is incredibly diverse. Some of you have terrible pain, like I used to have. I don't have pain anymore like that. Okay. He was wrong. That doctor who said I'd live in pain, he was wrong. Um, Others have absolutely no pain. Both of you diagnosed with IC. Are you the same? Absolutely not. Some of you have bleeding ulcers on your bladder. Others have completely healthy bladders. Are you the same? You're both diagnosed with interstitial cystitis. Are you the same? Absolutely not. And when you look at how patient symptoms begin, that's where you really see the diversity. I got a hair on my face. Okay. Because for some people, IC begins when they were children. For others, IC begins. IC begins. Hold on. I got a hair tickling my nose. After menopause. For some people, IC begins after having a baby, while for others, IC begins after chemotherapy for cancer. Are we all the same? Absolutely not. No way in hell are we the same. And a lot of you, I'm going to say the majority of you, your symptoms began after some sort of pelvic trauma. Okay. It could have been a history of athletics. I was working with a ballerina, again, another ballerina a couple nights ago. In fact, she runs pelvic pain exercise classes, and hopefully we'll be able to talk about that. I'm gonna go take one first before I talk about it, but that's interesting. But some of you may have a history of athletics, ballet, dance for men, football, bicycle, anything at all like that. And what we often see in this patient population is a history of pelvic trauma that literally begins in childhood. That in childhood, you might have jammed your crotch on the bar of a bicycle, or you might have fallen off of a horse, or you might have fallen on your tailbone. And of course, you have no clue that that is a significant injury. Life goes on. You probably didn't even tell your mom about it. But then when you're in your late teens or your early 20s, something else happens. Could have been a rape. Could have been you having sex for the first time. Could have been you having, pretty challenging sex. Could have you been being more of an elite athlete like I was. I was a professional tennis player for a while. And my workouts were insanely damaging to my pelvic floor. I had no clue what I was doing to my pelvic floor. And so we have injury number 2, injury number 3, and again, they're kind of mild. You don't really understand you're injured. You don't know that you've got trigger points in your pelvic floor that are starting to restrict blood flow to your bladder, that are starting to affect your vulva. And then for women, you have a baby. And that is a mega trauma to the pelvic floor. God forbid you suffer a muscle injury. That could be the straw that breaks the camel's back. Or you have a career where you're sitting for a long time, or you're bike riding or horseback, whatever. Again, it's this history of pelvic trauma that over time starts to damage the pelvic floor so badly, so dramatically, the blood flow ends up being disrupted to the bladder and the bladder wall starts to break down. I have talked about this. This, my friends, is the book of all books. This is the book that everybody should get. Breaking Through Chronic Pelvic Pain, a Holistic Approach for Relief by Dr. Jerome Weiss. This is the book that gives you the foundation of how your muscles, bones, bony structures, hips, etc., can be a problem. Again, when I was reading this Facebook group this morning, somebody asked again, it was about does physical therapy hurt? And somebody replied, yeah, it helps. And they can get rid of my trigger points, but they come back 2 weeks later. So what's the point? And the answer here is, well, wait a second. So you have trigger points happening in the same spot every single time. Maybe we need to figure out why a trigger point is happening every single time. And that goes back to your bony structures. Maybe you've got one leg longer than the other that's putting your pelvic floor at an angle. Maybe you've got a joint dysfunction, like I do with my left SI joint, which is again an injury from my tennis career. Or maybe you've got scoliosis, or maybe you've got a foot issue, Morton's toe, Morton's neuroma. I've been diagnosed with every foot condition you can possibly have, and I always assuming that it was because of my tennis, and it pretty much was, except I have mild scoliosis too, which could also put strain on the pelvic floor. So, for everybody who's new here, your first job is really to try to understand your unique presentation of IC. You are an anatomical mystery to be solved. You are different than everybody else. You are unique. And how do we do that? We do that with something called subtyping. because some of these subtypes are curable. When Dr. Chris Payne, this has been the competition around the world. Researchers around the world for the last 5 years are all trying to define these variant subtypes. In Europe, there are 16 variations of IC, each one with a different treatment. In Canada, there are 6. In the United States, we don't have an agreed upon system yet, but I use a system that was created by the doctor who ran the IC research program at Stanford University. And he proposed 5 core variants for IC. And let me get my slides here real quick. Where did I put them? I swear I already pulled them out. Okay, here's some of them. That is so, oh, here they are. Here they are. So hold on a sec here. Oh, that's another set of slides I can go through. Okay. So it was Dr. Christopher Payne who 5 years ago proposed a subtyping system, which is what I use and which is basically what most elite doctors in the United States, the elite IC doctors, the local doctors don't have a freaking clue what I'm talking about here. You got to understand that. These are the top tier doctors. Who, by the way, guys, a lot of urology clinics have closed because of COVID, because their doctors are reassigned to work with COVID patients. And I truly, 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 truly hope that you will send the best wishes and prayers ever for our urologists and urology nurses who we would normally work with, who have been reassigned and are now risking their lives. Our top IC research center in the United States is Beaumont Health outside of Detroit. And they are having a terrible time with COVID. And they have just lost their first doctor in the Beaumont Health system. And it is absolutely heartbreaking. So please, when you say your prayers at night, would you please say something for those lovely urologists who have helped us so much, who are now reassigned and risking their lives, and for all of the doctors and all of the first line workers out there. My cousin has COVID right now, and we can talk about that in a bit. But anyway, let's get back to these subtypes. So Dr. Christopher Payne, he's now at Vista Urology. He left Stanford after 25 years and is in practice with his wife, Jeanette Potts, who is also a pelvic pain specialist. And Vista Urology in San Jose, California, is the premier pelvic pain center on the West Coast right now. And again, there's a massive COVID outbreak down there too. It's really sad. He believed that there are 5 core variants, but when he introduced it in his journal article, he did it in a very, very provocative way, because he said we should treat IC patients like cancer patients. And of course, I'm reading this going, what? Please don't talk about cancer and scare people. There's no connection between IC and cancer. And his response to that is, no, 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 no. I'm not saying there's a connection between IC and cancer. What I am saying is, think about how a cancer patient is treated. They're not just told you've got cancer and sent on their way. They're given a very, very, very specific diagnosis. They're told you've got cancer of the left breast that is estrogen dependent, type 1, 2, 3. And that diagnosis is so incredibly specific that both the patient and the doctor know exactly what treatment they're going to do. They know exactly what they're going to do next. There is a clear, intuitive pathway. Where he says a diagnosis of IC, you get your diagnosis of IC, you don't know what the hell to do next. You don't. You have no freaking clue what to do next. Neither really does your doctor, especially local doctors. They pull out the textbook, they give you Elmeron, they give you DMSO, and they send you on your way. And he says that when a patient is diagnosed with IC, they should have a very clear, appropriate, individualized treatment pathway that will work for them. So how do we do that? We do that with a more specific diagnosis. Here, I got to drink water here. Hold on. I don't know how long I'm going to last today. I am just fried. So bear with me here. Okay. So what he said is we need a more specific diagnosis. So here are his variants. Variant number 1, Hunner's lesions. We now know that the quote unquote worst form of IC, which are big bloody wounds on the bladder wall, and let me give you a picture of that. So these are pictures of Hunner's lesions. They're known for their stellate appearance. They have a dark, bloody center, and they've got arms that radiate from it. Okay. These have been considered the worst form of IC, unresponsive to most therapies like Elmeron. Okay. Now we know why. Because these are now linked to viral infections. When you biopsy a lesion, you find massive inflammation. And it was researchers in Europe who made the connection and has continued even today to found the Epstein-Barr virus. If you've ever had mono, that virus is found in the bladder wall sometimes, or the polyoma BK virus, which is something we all have. And you know, guys, like we did last year, I swear every time I say the word virus, you need to take a shot of something. I'm not I'm not suggesting alcohol, but you know, it is the hated word at this point in time. But anyway, in any case, really the only subtype with a very clear disease process is going to be a Hunner's lesion patient. And Hunner's lesions are not treated with typical therapies. Hunner's lesions are going to be treated with a steroid injection to calm the inflammation, or with laser therapy, or with Lyris, also known as the lidocaine pretzel, right? Hunner's lesion patients clearly, because they've got these big bloody wounds in their bladder, are going to be incredibly diet sensitive. These are the patients who have open wounds in their bladders, and these are the patients who really have to stick to the diet. But this represents only 5 to 10% of the patient population. The rest of us do not have this process going on. And there is a movement around the world now to split Hunner's lesions entirely away from the rest of us, because they do represent their own unique disease. Okay. Now, again, we also have the first treatment in history to heal Hunner's lesions, known as Lyris, the lidocaine pretzel. They can heal lesions in after 2 weeks of treatment. Unfortunately, the pharmaceutical company that has it, known as Allergan, is sitting on it and is not making it available. So the only therapies available really for Hunner's lesion patients, besides diet modification and maybe some supplements to help reduce pain, are going to be, again, cauterization, laser therapy, or steroid injection. And you can come on over to our website and read our section on Hunner's lesions. All right. IC subtype 2 is bladder wall driven, because hello, the bladder, like any other part of the body, can be injured. So we know your bladder is driving your pain if you have, and your symptoms, if you have pain as your bladder fills with urine that is relieved with urination. So the fuller you get, the worse you feel, and as soon as you pee, there's a sense of relief. Now, what causes bladder problems? Number one, chemicals, chemicals, acids. You got to remember that our body was designed 5,000 years ago. You know, I mean, the latest evolutionary adaptation was begun 5,000 years ago. Obviously, it was designed hundreds and millions of years ago. But never in the lifetime, in a span of human species, have we been exposed to massive levels of acid. It's only really in the last 500 or 600 years. They were not drinking orange juice or lemonade or green tea or coffee 1,000 years ago. So the acid load, the extreme acid load that some people have, can certainly lead to damage to the bladder. We know that chemotherapy is going to damage the bladder. We know that ketamine is going to badly damage the bladder. We know there are a number of chemicals which can irritate the bladder really, really, really badly. But that's not a disease process, that's an injury process. And the good news here is that healing is always happening, that never turns off. But it's your job to create an environment that will support your healing. So, concept number one is chemical injury. Concept number two is estrogen atrophy. Because guess what? Your bladder relies on hormones to be healthy. Now, let me get this picture here real quick. All right. So here's a three-dimensional picture of your bladder wall. So you have a top layer of mucus, this blue layer. I mean, it's not really blue. This is just an illustration, right? Then you got underneath the mucus, you've got 4 to 5 layers of urothelial cells. Then underneath that, you've got blood vessels and you've got nerves. This thick blue barrier, also known as your gag layer, is a mucous membrane. The purpose of it is to act as a barrier. And you'll see that when the barrier is intact, well, hold on, it repels whatever's in your urine. When the barrier is damaged or thin, the irritants in your urine reach the cells of your bladder, and that is not a good thing. This mucosal barrier is estrogen dependent. So when you're young and you have lots and lots and lots of estrogen, guess what? You have lots of mucus. When you're older, or if you've had a hysterectomy and you have less estrogen, guess what? You have less mucus. That means that your bladder's ability to defend itself is compromised. We call this estrogen atrophy. Estrogen atrophy. It's not a disease process. It is not a disease. It is aging. So what's the fix for that? The fix for that, it might be some topical estrogen vaginally, or it might be using something that will give you a coating in your bladder, a little bit of extra protection in your bladder. And again, that's going to be Elmeron, although we now know Elmeron is associated with very severe retinal disease. So Elmeron's kind of off the table. Or it's going to be some of the supplements like Bladder Builder, Bladder Rest, or Cystoprotect, something with chondroitin in it, because it's the chondroitin that has been proven to help improve the integrity of the urothelial cells. Okay, so we know estrogen atrophy can cause frequency urgency pain. And we also now know, and we talked about this a little bit, there can be some chronic infections. It's considered a very small subset of this subtype, but there might be people out there with chronic fungal infections. There could be people out there with chronic bacterial infections. But it's not a big group. I don't believe that it's a big group. I think it's a smaller group. Because the third subtype, pelvic floor driven, is in fact the largest subtype. These are the patients whose symptoms began after a muscle injury. And so these are the people who symptoms, again, they were the athlete. There's clear cause and effect. Their symptoms began after a surgery or after a fall or anything like that, right? Or it could have been something very silent, little minor injuries, again, over time, that just slowly but consistently built dysfunction in your pelvic floor, created trigger points in your pelvic floor, which then eventually restricted blood flow to your pelvic floor. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved. They cannot not both be involved because they are so incredibly interconnected. But one is normally driving the other. And that's your job as a patient. That's the gift of subtyping, is it will help us figure out which is primary and which is secondary for you. So, if your symptoms began after chemotherapy, we know your bladder wall screaming in pain. And of course, your muscles are going to get tight in a guarding reflex to protect you. So, our therapeutic priority for the chemotherapy patient is to calm and soothe the bladder. We know that if we're going to calm and soothe the bladder, the muscles will eventually release. But we don't want to leave we don't want to treat your bladder and just leave tight muscles. That's not going to help because tight muscles are damaging too. It's the opposite circumstance. So the bladder muscle connection is called the viscerosomatic reflex. But if your symptoms began after muscle injury, now again, you have no freaking clue you've got a muscle injury. And then finally, one day you've got frequency urgency. You call your doctor, hey, doc, I think I have an infection. Doctor goes, okay, let's try some antibiotics. Your culture might even come back negative, but the doctor still says, well, let's try antibiotics anyway, just to make sure. They don't work, or it keeps coming back. You go back to the doctor. The doctor goes, well, maybe you've got overactive bladder, and they give you overactive bladder medicine. And they don't work. You go back to the doctor. The doctor goes, maybe you've got interstitial cystitis. And they give you the Elmeron and the IC meds, and they don't work. And you're stuck. You're just taking bladder meds, bladder medication after bladder medication after bladder medication. And if you're one of these patients, bladder medications will never fix you because our therapeutic priority for these patients is not to calm and soothe the bladder, it's to restore blood flow. If your muscles are so tight, they're restricting blood flow to your bladder and your vulva and everything else down there. It's going to be really hard for your bladder to be healthy. So if these patients, our number one goal is not bladder therapy, it's pelvic floor physical therapy. We got to get those muscles relaxed. We got to restore blood flow. And once we restore blood flow, then we have a chance for the bladder to heal. And again, when Chris Payne proposed his subtyping system, he said, it is so incredibly unfair to tell patients this is incurable because this subtype is curable. Pelvic floor muscles respond beautifully to pelvic floor physical therapy. Beautifully. And I'm living proof of that. And many of you are living proof of that. But we've had large studies. We had in 2008, our first pelvic floor physical therapy study was released by the National Institutes of Health, and it proved that pelvic floor physical therapy outperformed every other bladder treatment 2-to-1. And when that study came out, guess what? It turned the IC movement on its head because it was at that point that everybody went, oh, wait a second. You're saying that a muscle therapy would treat a bladder condition? Maybe, just maybe, that means that it's not a bladder condition in quite a few patients, that maybe it's a muscle issue. And so do not underestimate the value of pelvic floor physical therapy in treating this. Listen, if you're one of those people where, what are the symptoms of pelvic floor dysfunction? Not pain before urination, but sometimes pain after urination. It's bladder pain tends to be very sharp and shrill. It's described as razor blades. Pelvic floor pain is duller, it's achier, it has a burning quality to it. Somebody with pelvic floor dysfunction for a woman will often have vaginal burning. For a man, they will have rectal burning. There are a number of women who honestly, they've dreaded having their annual pelvic, or they've dreaded sex their whole life. Why? Because they have vaginismus. They've got tight pelvic floor muscles that probably began in childhood. And again, it could be because of injury, but it also can be because of how you were trained to go to the bathroom. Or if you were a bedwetter. There are some parents out there who, if their child was a bedwetter, the children got spanked badly. What do you think that's going to do to a child? What are they going to do? They're going to subconsciously or consciously tighten their pelvic floor muscles. And over time, what happens is they never learn how to use them properly. Their muscles are always tight. I worked with a very, very sad case a couple weeks ago of a man whose pelvic floor muscles were like concrete. They were so hard. And, we kind of go back in time and we're kind of, that's one of my jobs when I do coaching with patients is we kind of go back in time to try to understand the foundation. And Maddie, I'll come to Elmeron in a second. or in a couple minutes. We're trying to figure out what the hell happened to his pelvic floor to make him like concrete. And it turned out that his mother forced him to have enemas every morning before school. If he didn't actually have a bowel movement before school, she forced an enema on him for years. Now, what do you think that child did? Massively tighten their pelvic floor. Now, the cool news is that muscles do respond beautifully to therapy, but they need hands-on therapy. This means, my friends, this is going to be a finger up your you-know-what. It is. It is. If you go, so generally now, every major IC clinic, the top tier IC clinics, one of the very first things they do when you go is they do a pelvic floor examination. And they will insert their finger in your vagina or your rectum. If it's tight, it's like, okay. I mean, come on, it takes 5 seconds. They'll know immediately if it's tight because it feels like tight piano strings. They will immediately refer you to a pelvic floor physical therapist. It is that pelvic floor physical therapist job to then try to figure out which muscle group is the problem. So when you go to the pelvic floor physical therapist for the first time, they are the epitome of the puzzle solver. They're going to study your pelvis. They're going to study your legs. They're going to watch how you walk down a hallway. They're going to measure your legs. Is one leg longer than the other? And then they're going to touch your pelvic floor. And remember, here's your pelvic floor. You've got muscles that go from left to right. You've got muscles that go from front to back. Those are your levator anal muscles. You've got muscles that go from low to high, like your psoas muscle. And so what they're going to do is very gently touch muscle groups. And if they can reproduce your pain, hallelujah, baby, that is exactly what we want. That is a tremendous success. Because if they can touch a muscle and reproduce your pain, it means they found it. Don't be afraid of pain during that first appointment. You want them to find it. And you have to be very verbal about this, my friends. You've got to tell them, hey, it hurts. Okay, that's it. That's the spot. Don't push anymore. That's it. And then you ask them what it is. Oh, I'm doing a meeting. I can't eat right now. So just save that for me, okay? I'm not a pretty eater online. You don't want to see me eating doing a support stream. Thank you, Mom. My mom is 91 years old. I am her caregiver along with my dad. So again, during that pelvic floor assessment, their job is to touch muscles. They're going to do shallow muscles, mid-level muscles, and deep muscles because you've got 3 levels of muscles. And somebody just asked here, would pelvic floor physical therapy help your urethral pain? Absolutely. Because guess what? You've got muscles called the urethral diaphragm muscles, really, really shallow muscles that if they're tight, they cause frequency urgency. So if you feel like you're peeing through a needle, that could mean that these muscles are very, very tight. And again, this book is a phenomenal book. It is a master class in pelvic anatomy. I've read it twice. I'm going to read it a third time when I get the chance. And this will help you understand, when you read this book, and guys, it's freaking free on Kindle Unlimited. It's free. Sign up for Kindle Unlimited. It's $4. You can get all sorts of books for a month. You can get this book for free. Do it. Do it. It will teach you more in an hour than any doctor. It will teach you more about IC than even doctors learn in medical school right now. This is a master class in pelvic pain. And the patient stories in here are absolutely fantastic. It took Dr. Weiss 15 years to write this book. And it is a love letter to the IC patient community. And the illustrations are fabulous. And so he will show you the muscles around your urethra. He names the muscles. See, look at this. I don't know if you can see this. Here. Here are the 3 layers of muscles in a man. And here are the 3 layers of muscles in a woman. So these are the shallow ones right at the surface. Then you've got the middle ones, and then you've got the deep ones, right? And so any one of these muscle groups could be screwed up. Dr. Weiss tells a story that his wife was a ballerina, and she was doing the splits one day, and she tore her adductor muscle down there. And he said it's haunted her entire life. Just that one muscle that she tore. Okay. So So you have your pelvic floor examination, bam, they find, hey, look at that. It's your levator ani muscle. It's spasming. And it's like, okay, cool. What do we do about it? And then what they're going to do is they're going to do some gentle movement along the length of the muscle and then maybe also across the muscle. If you have trigger points, they're going to be looking for little muscle knots in there. They're going to try to release those trigger points. But more importantly, they're going to give you things to do at home. Because truly, the most important part of pelvic floor physical therapy is what you do at home. As an example, most men and women who have pelvic floor dysfunction, oh, look at that, I almost did it. Hey man, you know it's not a support group meeting if I don't accidentally drop my chair or something doesn't fall. I almost did it. Did you see? I just dropped an inch. Most patients with pelvic floor physical therapy are usually asked to get a wand. This is a Pyrex glass wand, and this is made by IC Relief. This was called Easy Magic. There are 3 different types of wands. You can find those in our store on our website. This is what you would use potentially to try to find those muscles, to find those trigger points. And it's hard. My IC skills are really, really good. I mean, obviously, since I've written most of the materials that you've read about IC, I've written the vast majority of them, other than the diet ones, because the diet ones were written by Julie Beyer, the registered dietitian with IC, or Bev Lauman. But I know my stuff. My skills are really, really good, and I will tell you that after my hysterectomy, and I was having all these terrible levator ani spasms, the physical therapist kept saying, use a J motion. When you're laying on your back and you're just trying to figure it out, it's like, what the hell's a J motion down there? And the last thing you kind of want to do is just kind of poke and prod. You don't want to do that. You have to really understand where the muscles are and what direction they go. So again, as an example, your levator ani muscles go from front to back, right? Whereas your piriformis muscle tends to go up. It's up the sides. Your pelvis is a 3-sided box. And again, it was this book that really helped me visualize where I was working and how to do it. And now I'm pretty good at it. But it's weird, it's not something that anybody wanted to do. It's not something it's uncomfortable and awkward at first to be doing something like internal work for pelvic floor issues, right? It is, but it's doable because that's the only way you can reach these muscles is internally. So don't be afraid of. If you have any questions, you're welcome to give me a phone call. There are some fabulous physical therapists around the country. We have a list of physical therapists on our website, and also a list of IC doctors. IC subtype 4 is pudendal neuralgia. This is a nerve injury. And Dr. Weiss believes that far more patients have nerve injuries than they realize. So if you have a fluttering sensation, we call it a fasciculation. If it feels like you're sitting on a cell phone on vibrate every now and then, that could be a nerve that's being compressed. Or you might have sciatica, pain shooting down your leg. Ultimately, in the end, these nerve patients, what we're going to do, number one, is they're going to try to figure out what's impacting the nerve, what's pressing on the nerve, which is usually tight muscles. And then they're also going to do therapies that will calm nerves down, like Neurontin, or subcutaneous lidocaine blocks, or lidocaine on the skin. And guys, I'll get to your questions in a minute. Let me just finish this up. IC subtype 5 is central sensitization. So this is one of my subtypes. Central sensitization means that in many cases it's inherited. Hello, redhead. We have more nerves. Our nerves have a lower threshold. It's easier to turn our nerves on. So people who are sensitive, we have very, very sensitive skin. We tend to have a sensitive stomach. In fact, I blew my stomach out 2 nights ago, and I'm still getting better from that. I'm not quite sure what did it. We have a sensitive bowel, we have a sensitive bladder, we have a very wicked sense of smell. We can smell things that other people cannot smell, and smells drive us crazy. We might even have visual sensitivity where if there's a funky pattern in a carpet or a wallpaper, we got to close our eyes and turn away. So people with central sensitization, in many cases, it's a gift of our ancestors because hello, we were needed by the tribe because we could smell the good food versus the bad food. We could find the good water versus the bad water, et cetera, et cetera. So being sensitive is a gift, but in today's society, being sensitive is hard because there's a lot of stuff that provokes us and a lot of stress that provokes us. So somebody with central sensitization, the odds are you've already changed your life. You've already gotten rid of the chemicals. You're not using Febreze. You're probably not happy in a big city. You're probably more comfortable in the country or in suburbia. Um, and you can read more about central sensitization on our website. So, using the pain subtyping system, I am IC subtype 5 and subtype 3. I'm IC subtype 5 because I'm a redhead and I'm wicked sensitive. The word sensitive has haunted me my entire life. And it's really sad that the word sensitive has been weaponized. You know, if people accuse you of being sensitive, it's like you have to understand that biologically, sensitive is about how your nervous system works. Our nerves are easier to turn on. We can't get over that. That is how we were born. And again, it's a gift because we're going to be the ones who smells the fire first, right? We are often the people who figure out that there's a problem sooner than others. So my job on a daily basis as a central sensitization patient is to just kind of calm and soothe my body and try not to put myself in a situation that is going to be incredibly stressful and irritating. I don't allow smoking in the house. You know, I'm just very careful with chemicals and other stuff like that. But my dominant subtype also is that I have a critical pelvic floor injury on my left side with my piriformis muscle and my SI joint. And so my bladder, if you looked at my bladder, perfectly healthy. And yet, honestly, I have sensitivity. If you put 500 cc's of water in a normal patient, they can walk around for hours. You put 100 cc's of water in my bladder, I need to pee. That is the epitome of somebody with central sensitization. And I should also say that central sensitization happens after injury sometimes too, you know, because nerves are connected to other nerves. When you suffer an injury, you know, think about all those people who, especially us older folks, which is so weird for me to say because I feel 25 inside. It's so weird to be older. Think about those people who have sustained a knee injury, you know, years ago, and yet whenever the weather changes, their knee aches. Why? Because when something gets injured, not only is your bone broken and your muscles injured, your nerves are injured. And an injured nerve becomes a sensitive nerve, and it's just easier to turn on. All right. So those are the 5 subtypes of IC, according to Dr. Christopher Payne. And it's what I use every day. And I think it's absolutely fabulous. Now, obviously, I can talk forever. And let's not do that. Let us take your questions. Actually, I'm going to go get some water first. I'll be right back. I didn't drink a lot of water this morning. So hold on. All right. So you guys, I do simulcast live on Facebook and YouTube. When I'm looking up here, I am looking at Facebook. When I'm looking down here, I am looking at YouTube comments. We have people in both rooms right now. And you guys just know that Facebook does not allow me to scroll back. Facebook changed all their controls. I really can't even see how many people are in Facebook right now. So, Jessica says, have you tried Azo urinary pain relief? I use this and it was recommended by a urologist. And so Azo is a over-the-counter version of pyridium. And what it does is it numbs your bladder wall. So if you're having a bladder wall flare, Azo is a viable option. So everybody really should have Azo. If you're IC subtype 1 or IC subtype 2 or even 3, but your bladder wall's compromised by tight muscles, having a little bit of Azo in your IC toolkit is a good thing. It's just really not meant to be used every day. It's meant to be used for short periods of time. Hello, Danny from Waycross, Georgia. Hi, Sue. Hello, Amy from Colorado. Nice to see you, my friend. Amy says she's in the middle of another flare scheduled for another hydrodistension in 2 weeks. I hope you get it because a lot of optional surgical procedures like that have been canceled. So make sure it wasn't canceled, hon. Most, at least here in Kaiser Permanente, has canceled everything, every therapy like that. You can't get installations or do non-critical surgical procedures right now. Hello, Donna. Hi, Mary. Grace says on YouTube, my IC is under control with diet, but now I'm dealing with estrogen atrophy. Didn't know it could be so painful. Girl, I mean, don't you wish? It's kind of like your mom talking to you about sex when you were a teenager. Like, would you please, it would have been really nice to have a nice discussion about that. My mother never talked about sex. It was my sister who taught me about sex. But I also really wish that mothers would actually talk about what happens as we get older and estrogen atrophy, because so many women that I work with, and educated women still don't know the importance of estrogen to their urinary tract. Jen says, my cousin has been telling me to try LDN. She has Lyme, and it's one of the only treatments working for her. Awesome. Hello, Amelia. Hello, Holly. Jennifer says, the doctor wants me to do a PNE. What do you mean by PNE? PNE stands for pudendal nerve entrapment. There must be another name. Does he want to do a nerve block on the pudendal nerve? That's a viable, real effective diagnostic method as well as treatment method. Is if they can block the nerve with some lidocaine and turn your pain off, then we've got de facto proof that you've got pudendal nerve entrapment. Samantha says, what are your thoughts on pelvic floor therapy? I've been going for a year to physical therapy and IC, and it's been a life-changing for me. I was in a bad flare this week going to PT, and the flare was so much better afterwards. Pelvic floor physical therapy is proven in research studies as well as in virtually every clinic of the top doctors to be the most successful and important and viable therapy for patients. It changed my life. Dottie right here on Facebook says it changed her life. John Lee's talking about being floxed with Cipro or Levaquin. Jennifer says, what do I know about pudendal nerve entrapment? I know quite a bit about a pudendal nerve entrapment because I've got a partial pudendal nerve entrapment on my left side because of my piriformis muscle. And in my case, it manifests as it's just starting right now. I get a twitching, a fluttering right in that nerve if I sit for too long. It's really the thing that has changed my daily life the most. My pudendal nerve entrapment started, I'm going to say about 10 years ago. When I started the IC network, I could sit for 10 or 12 hours and write about IC and build our website because I personally built our website for many, many years. And then one day I sat too long and I felt this fluttering in my left butt cheek. It's about 2 inches from my tailbone on the left side. And I was like, what the hell's that? But I had already worked with some patients who had pudendal nerve entrapment, and I already knew that what that symptom was. And so went to my OBGYN, we did a nerve block. Yep, pudendal nerve entrapment. And um, another factor that I relate to, at least my pudendal nerve entrapment, is that I don't have a butt. You know? I mean, like, the women in my family, we're flat. The men in my family have 0. They have no butts at all. I just I have muscle there, but I don't have a lot of fat, and so when I sit for long periods of time, honestly, I was just sitting right on the nerves and directly compressing the nerves just like a bicycle seat would. Okay, now I have already hit my chair seat twice. Hold on. See? So I have a lot of chair cushions, and we sell some pudendal nerve chair cushions on our website where if you start, I mean, because it's all about the sitting. If sitting hurts and standing up makes it better, you have a pudendal nerve entrapment. It might be mild, it might be severe. And again, that's something that in this book, Breaking Through Chronic Pelvic Pain, Dr. Weiss discusses in depth. And so you're not supposed to sit to the point that it hurts. I can usually last 3 hours, maybe 4 hours at the most, but I would usually whip out one of my chair cushions to make it better. Let's see here, Facebook. Oh, Lauren says she lost their home and vehicles in tornadoes on Easter. Holy moly. Here, hold on a second, guys. Wow. Oh, hun, I'm so sorry. Oh, this world right now is something else. I was reading an article yesterday that talked about, we're all dealing with the stress of COVID, which is real. Uh, um, and it talked about how do we respond to a natural disaster in the COVID era, because we're entering fire season again in just a couple of months. And we've been, out of the last 3 years, evacuated for weeks because of fires that have come within 2 miles of my house. And how are we going to evacuate and go to an evacuation center when we have social distancing? So the stress is real. Guys, um, there is no one untouched by this. There is no one. You might say you're okay. You might say that you're handling it well, and you probably are handling it well. I mean, I think I'm handling it well too. But that said, that doesn't mean that you're not feeling that stress in your body. And what happened for me is I went back to childhood grinding my teeth at night. I hadn't done that in 30 years. And then all of a sudden, I had all this pain right here for weeks. Even took antibiotics because we thought it was a sinus infection. I was freaking grinding my teeth. And so I brought out my old tooth guard, which of course didn't work. We tried to fix it, it didn't work. And then I called the dentist. They're not seeing people. Even if you have a cavity, you can't get into the dentist here in California right now. And so luckily I ordered a couple of mouth guards on Amazon, and one was perfect because I could mold it to my teeth. So I've used it 3 nights in a row, and my pain is 10% of what it was. It's amazing. So understand and respect the fact that while you might be, if you're, oh, and there was this other great story. Oh my God, it was so funny. And I felt this. And bear with me here because words, I might say words that I would not normally say in a support group meeting. Um, but I was out because we have a really active caseload of COVID in my town, right? And so you're desperate to get out of the house. You go walking, and so I'm walking. I'm keeping my distance. I'm wearing my mask, and a runner comes up behind me and like literally rubs my shoulder, huffing and puffing, and like it's like, oh my God. Seriously, you couldn't go 6 feet, and now I'm breathing his air, and he's huffing and puffing. So I think I'm going to cross the street, but no, there's another runner coming down the other way, and I'm like standing there going, "Damn it, dang it, dang it, dang it, what do I do?" And um, somebody was telling the story of another girl who was in exactly the same situation, and she just stopped and she just screamed the F word to the entire community, and I totally, totally get that. Sometimes it's okay to curse. It's okay to curse, my friends, as long as you're not hurting somebody else. We have to be kind to each other. We're all under stress. Hopefully, you're looking out after your neighbors. I have been making face masks for all of my neighbors and all my family. This is my latest one. How pretty is that, right? And I'm making it with strings now, right? And it's pretty. I'm really happy about these. It has a pocket. And so I've given away about 40 of these so far. In fact, once I've got everybody here situated, I will make some for you guys too. And then for people, the macho guys, we got blue, right? So anyway, do things for your neighbors. Look out for your neighbors. Be real. The stress is real. You got to make sure you do things for yourself. Give yourself comfort. Whatever will make you happy. Sometimes that's just what you have to do. If that means you're eating an extra cinnamon roll a day, that's okay. I've got a cinnamon roll belly right now. It is what it is. It is what it is. All right. Kelly says, I'm so familiar with that flutter. I did pelvic floor physical therapy for it. I was so relieved to know others had this. I kept describing this as a cell phone on vibrate. Kelly, I got to say, the first patient I worked with who taught me about it was a guy, a business executive, who literally, whenever he sat down, his penis started vibrating. And he said it was so violent, it would throw him off the chair. And that's real. I mean, that's real. If you've had this, if you keep sitting, the vibration gets deeper and stronger and stronger and stronger, right? And again, Dr. Weiss in the book, he says, listen, defense number one about pelvic floor and pudendal nerve entrapment is absolutely making sure that you're not sitting incorrectly. As soon as it starts vibrating, you got to change your position because that's telling us that the nerve is being impacted, right? So, Lauren, I'm sorry, getting back to you. I'm so sorry about your house. I'm so, so sorry. Hi, Deborah. Vicky says, is there evidence that chronic infections are a small minority? Yes, there is, because I will tell you, and in fact, we just had yet another study that was released in a journal last month that they consistently do not find infection, chronic infection in the IC patient community. The best evidence that they're finding is chronic fungal infection. They're not finding chronic bacterial infection to the degree that some people would like to think. There's a small group of patients who believe that every patient has chronic bacterial infection, and they're completely discounting the role of viral infection and fungal infection. But it's the fungal infections that our National Institutes of Health keep focusing in on. Anita says, I had severe bladder spasms that were horrible. In December, I had 2 inguinal hernias removed. When the surgeon learned I had a partial hysterectomy years ago, he determined I didn't need the round tendons that attached my bladder to my uterus anymore. He removed them, and I haven't had any more bladder. Oh, that's cool, hun. So, Anita, you're an example. And this is something that I also consistently see are surgical injury patients. There are patients out there who have surgical injuries. And who is it? Oh, let's see. Again, last week, I was working with a patient whose symptoms started after, what did she have? Oh, okay. So she had fibroid tumor. No, was it fibroid tumors? She might have. Okay. Well, anyway, she had her ovaries removed first, And she had no problems with her bladders. Even at the point that her ovaries were removed, she had zero problems with her bladder. And then um, they found that she had a couple of pretty big fibroid tumors in her vagina, and so they did the rest. They removed her vagina, they removed her cervix, they removed her fallopian tubes, and it was on waking up from that surgery that for the first time she had bladder pain. She had no frequency urgency bladder pain before this. What she did have was just pelvic pain from the fibroids, but she had no active bladder symptoms until the surgery. And something happened in the surgery. And I've worked with many of you on the phone, and in some cases what we ask you to do is to go back and get your surgical record. I mean, if you ever come back from the hospital with a catheter, your bladder was damaged. Okay, if you have a hydrodistension and they send you home from the hospital with a catheter for a week, your bladder was damaged. Your bladder was ruptured. If you have a hysterectomy and they send you home with a catheter, that means your bladder was damaged. I had a hysterectomy. I was home in 3.5 hours, no catheter. They did a hydrodistension afterwards to make sure they didn't damage my bladder, and they didn't damage it. So sometimes there's a surgical injury that happens. DJ says, I get an infection every single month. Right now, I have enterococcus. Ooh, VRE resistant. Ooh, girl. Well, I'm sorry. I'm not sure if you're a girl or not. I apologize. DJ, you might be a guy. I can't tell because your picture is really small and I have my screen really small. So if you are a girl and if you are of a certain age, then understand that there are a group of women who, once they enter estrogen atrophy, they develop more infections. And they can have a true infection every month, verified by culture and everything, right? I attended a fabulous lecture by Dr. Anthony Schaefer at the American Urology Association several years ago. And he talked about this group of patients. And what did he say? He said, number one, we never ever diagnose these patients with a simple UTI. We always diagnose them as a complex UTI. And since you have a drug resistant infection, for sure, you're a complex UTI patient. And they have studied these patients, and I mean, in these research studies, they take daily urine samples, they've taken daily vaginal swabs, they have tried everything they could to try to figure out why these patients got recurring infections all the time. And they made a fairly stunning discovery, and that is that the bacteria is usually found in the vagina 24 hours before it arrives in the bladder. And that then force them to ask the question, well, what the hell's happened to vaginal health? Why has the vagina become a safe haven for bacteria? And the answer comes right back to estrogen atrophy, because your vagina relies on that nice thick coating of mucus to protect itself from bacterial infection too. And if you are menopausal, you don't have a lot of mucus down there. So it's kind of wide open. Plus, there's a change in pH, which favors bacteria. And so DJ, again, if you're female, I would suspect that you've got some estrogen atrophy going on, which is contributing to it. Guys, another piece of advice that I always give to patients, and remember, it's not my job to give you medical advice. I don't give you medical advice. I'm basically trying to educate you. So let me take back my word advice. The other thing I suggest that patients do, if you are somebody who you keep getting recurrent infections, is never accept you have an infection. That's not enough information for you. You need to be able to know what kind of infection it is. You should be writing it. You should be writing down the type of infection every single time so that we can track what the bug is. We can track, is it E. coli over and over and over and over and over, or is it staph, or is it strep, is it enterococcus? If it's E. coli all the time, then we're going to say either you have a drug resistant E. coli infection or you have an exposure, a daily exposure to that E. coli. And our number one suspect is always going to be a bathtub with jets. If you've got a bathtub that gives you air bubbles, the jets are supposed to be installed at a downward angle so that they drain. If they're level or they're upward, they become a safe haven for very, very, very long-term chronic infections, and that was discussed by a Center for Disease Control in research years ago. Um, Also understand too, there's this perception that if you get infection, it's about poor hygiene. That is not true anymore. Now we know a lot of infections come from food. There was a very famous case of college students in Washington, Oregon, and Idaho who all got this really rare bladder infection. And it was a very, very rare infection, and hundreds of students had it. And they were able to trace it back to a slaughterhouse that was selling beef to college commons commissaries. And so infections come from food frequently, frequently. So, DJ, that's probably where you got your enterococcus infection, and I truly hope that you're doing well. But you got to ask your doctors why. What is it about your body that is making your body a safe haven for infection? And it could relate right back to estrogen atrophy. Jean says in the United Kingdom, we believe chronic infection or embedded infection is common. I know. Yeah, I know. And unfortunately, you guys, it's like a one it's you hear me in these support group meetings. I always say I don't like broad brushes. We can't make all or nothing statements about this patient community. We can't, because it is an undeniable fact that many patients have underlying muscle problems, and that we believe that they are the largest support group, the largest subtype or subgroup in the patient population. But I would just encourage you to look at the fungal research and the viral research too. We can't say everybody has bacterial infection. The fungal research is real and it's consistent. And there are multiple studies from the best researchers in the world showing fungus can play a role in creating, you know, quote unquote, bladder infection or bladder irritation. Okay. Dang it. I hate that Facebook will not let me scroll back. And you've had some good questions. There were just some good questions, and I cannot see them. So, Nancy, I bet. So Vicky is just saying that she had a rip-roaring real infection, but they didn't test for infection because they thought it was a flare, and that happens too. It happened to me. You know. Um, there is a process of elimination here. When you have symptoms, we want to kind of slowly and steadily rule stuff out. And that's why having a dipstick test might be useful, although it's quite questionable in terms of real accuracy. But that could be one clue. And there's no shame or blame in asking for a urinalysis or a microgen next gen urine test. Nancy says, I know a psychologist whose 85-year-old mom had a urinary tract infection and affected her emotionally so badly she thought she had died. Her emotions were affected so much by her UTI, it caused psychiatric symptoms. They lived 1,000 miles apart. He zoomed with her for days before they figured it out. She's better now, and I'm teaching my friend not to give her acidic foods. Infections happen, especially as you get older. Because cleanliness is an issue too. I mean, take it from somebody who cares for a 91 and a 97-year-old. I've given enemas to both of them. And cleanliness is real. And often they don't know that they've had accidents. You know, it just is what it is. Nancy says, one more thing I learned from you. You have empowered me. Thank you. You are very welcome. Lauren says UTIs in older people show up with psychological problems more than physical problems. It's so strange. My grandmother had one while recovering from a broken hip. She was going crazy thoughts. Thought she was having a breakdown. No physical symptoms. Doctor tested her urine immediately and found UTI. She had IC as well. And she says, I think IC can be genetic driven as well as driven by PFD infection, pudendal nerve entrapment. Yeah. Well, and the genetics is really the central sensitization more than anything else, unless you happen to have a birth defect in your family where you've got a fistula that connects your rectum to your urethra, which would introduce constant bacteria from your rectum to your urinary tract. Or you have a birth defect. There could be birth defects too. Vicky says, I'm a redhead. I can't tolerate loud or sudden noise. Yep. Lauren says, I've contacted lawyers about Elmeron. It's crazy. They're saying if you're on it for 2+ years and have symptoms, that our case can be taken to court. My vision up close is so bad now. Hair still falls out. They should have to pay for vision loss. I mean, losing your vision is huge. Well, we do have our first filed case in the U.S. District Court in Connecticut by a patient who has sued Teva Pharmaceuticals and Janssen Pharmaceuticals about her Elmeron eye damage. I think that we all owe this patient a tremendous debt of gratitude, and I have it right here. So for those of you who might not know, we now know that pentosan polysulfate, also known as Elmeron, Curtis says, hi, Jill. Just wanted to let you know that I still listen to all of your live casts. I'll listen to them after you air them back and forth to work. Cool. Curtis, I'm glad that they're helping. All right. So anyway, so we now know researchers at the Emory Eye Center a year and a half ago presented a paper in which they believe that long-term use of pentosan polysulfate, known as Elmeron, leads to something called pigmentary maculopathy. What that means is that the retinal cells change color and lose their function. Their function begins to diminish. And one of the mistakes that happened back then, the people didn't understand, is when you're trying to establish a new disease, you want to show proof of damage first. And this was their first paper: pigmentary maculopathy associated with chronic exposure to pentosan polysulfate. This was a case series of 6 patients. They weren't making any claims about population data. They're talking specifically about what they are seeing in the eye. So they presented 6 patients who have used Elmeron for short to long periods of time. And let me just show you some of the pictures. Right? So this is a time sequence. First appointment, second appointment, third appointment. So you can clearly see the retinal cells changing, right? Small dot, bigger dot, lots of dots. Small cluster, dark, bigger dot, bigger dots. But the more meaningful picture is, let's see if I can, look, here's another picture of the eye damage, right? There's a 3-dimensional picture here. Here it is, that I think is really meaningful. So this is, I want you to look at this. This is the retina from the side, okay? And I don't know if you can see these spots. You can see these spots right here. That's really the cells that have changed color from the side. So that is the classic pigmentary maculopathy. So anyway, that's now been affirmed in many, many studies. But again, the mistake people made is, well, it's only 6 patients. Clearly, it's not a big issue. They didn't understand the point. The point was just to prove the damage. We now have 2 population clinical-based studies show that at best, 20% of Elmeron users have eye damage. And according to our own survey, at worst, over 50% of patients using Elmeron have eye damage. And in this study of the 6 patients, The patient with the most severe damage was the youngest patient who had only taken it for 6 years. And in our survey, we show patients showing eye symptoms in their first year. And these researchers did their due diligence. They found an early Elmeron FDA study which showed eye complications in the first 4 years. So the company knew that eye issues were happening, but they didn't talk about it. If you look at all of the old patient education materials, see, here's one of the biggest patient education. I mean, we all had these 15 years ago, right? These are great. And they talk about the most common side effects for blood and stool, diarrhea, nausea, hair loss, headache, rash, upset stomach, abdominal pain, liver function abnormalities, and dizziness. There's no mention of eye issues here. And there should have been. I think that there should have been. The only place you see any of the Elmeron materials talking about eye issues is in the drug information sheet, the drug information sheet that comes with it. And under side effects, it's on the back page. And it's like literally the last line. So, you know, we were all floored. When this Emory study came out, it's like I was sitting here crying. I mean, I kid you not. Listen, I've had to share bad news to the IC patient community. This is the worst news I'd ever had to share because I knew that thousands of patients have used Elmeron and potentially could have permanent eye damage. And so I went to my medical board. I asked them what they thought. We did our survey, and then rather than hiding the information, I decided hey man, informed consent. You should know what the risks of your potential treatments are. And so I was the one who broke the story to the patient community. I didn't want you guys to come back to me 2 years later and say, why didn't you tell us? I mean, I made my first article about it 48 hours after I found the research. Oh, scary, 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 scary. I don't want to, I hated the fact that I was going to upset some of you and scare you, but y'all should know because if you're on the medication, you got to go have your eyes examined. And if you have any change in your vision, you got to get off of the medication. That's what the doctors say is that, this is potentially permanent. And the sooner the eyes, as soon as you see any change in your vision, you have to go get your eyes examined. And it's very, very, very important that you get off the medication. So anyway, here's the first lawsuit right here, U.S. District Court, District of Connecticut, against Teva, and we have to give a big shout out to Kimberly, who's the one who filed this. Here, hold on, Facebook just got weird again. And basically, I've gone through the complaint in depth in a blog on our website. You can go over to our website and read it. But basically, what they do, they call it a failure to perform. That Elmeron failed to perform as necessary, and that that they have made no attempt to inform patients about this possible side effect. And I would agree with that. And they compare this to Plaquenil. Plaquenil is used for lupus. It's what people are saying might be helpful for COVID, although those clinical trials have been stopped because if you take too much of it, it will stop your heart or mess your heart up. But at least with Plaquenil, there are very, very clear warnings on the labeling. Massive warnings on the labeling. And with Plaquenil, they urge patients taking Plaquenil in their very first year to have a baseline eye exam so that they can follow their eyesight over the years to make sure nothing has happened. And yet they compare it to what's known with the Elmeron packaging, in which there are no warnings. And in fact, the label for Elmeron says there are no warnings about anything. The label for Elmeron has been updated on 5 occasions. At no time has it contained any information about vision loss, including pigmentary maculopathy. Elmeron is known to take a long time to exert an effect, and patients who are prescribed Elmeron are advised to take the drug for at least 6 months. For those patients who take the drug is known to be used for long-term use and is expected to be used for years, if not decades. And yet, what the research studies are clearly showing is that the longer you take it, the more you're exposed to, the greater the risk of eye damage. So, anyway, the first lawsuit has happened. Many more, I'm sure, will be filed. And what's going to be important here now is discovery. It's going to be absolutely fascinating to see how the companies respond to this. We submitted our data to the FDA 2 years ago, or no, a year ago, where we asked the FDA. I presented our data from the IC network, which the American Urology Association said was excellent research and excellent data. And we submitted our data asking for a labeling change, and we were denied. We were told that this administration has other priorities. We need to get that label changed. And if I can find the time, maybe this summer, I will submit another round of data to the FDI. Donna says, my hair would come out in plumps. It was scaring me. Also, my vision is so bad. I'm waiting to get over the virus to go to the eye doctor. Girl, do you have COVID? Oh, hun, if you do, I'm so sorry. And I hope that you're doing well. Larissa is watching from South Carolina. Hello, my South Carolina friends. Holly says, did you have petechial hemorrhages in your bladder on hydrodistension? No, because they did a low pressure, short duration hydrodistension. Remember that it was, when was it? I want to say 2005. We had our, right around then, we had our first research study that proved that the hydrodistension method itself caused bladder damage and false positives. So if you look at the AUA guidelines for interstitial cystitis, you will see that having a hydrodistension is no longer the gold standard diagnostic method for IC, nor has it been for well over a decade. Why? Because when you stretch the bladder, you damage the bladder and it causes petechial hemorrhages. And so the AUA guidelines are crystal clear that if a hydrodistension should only be done if the diagnosis is in doubt or if they need to treat Hunner's lesions, and because it can cause false positives. And if you are going to have a hydrodistension, you want to do a low pressure, short duration test rather than a high pressure, long duration. In the old days, it was very macho, and they thought the more you stretch the bladder, the better the benefit. But what happened back then is that patients' bladders ruptured. So now the AUA says no more high pressure. We want you to do low pressure, short duration to minimize trauma to the bladder. And that's what I had. So no, I did not have any petechial hemorrhages in my bladder when I had my hydrodistension 3 years ago after my hysterectomy. Hello, Destiny from Georgia. But DJ, why are you having a hydrodistension every 3 months? That's actually really rare. It's a tiny, tiny population of patients who do that because the risks of going into the OR and the anesthesia, are compelling. Interestingly, though, Donna, who runs our forum, is a woman who does have hydrodistensions fairly frequently, and that's just what she has to do. She also has spinal cancer, so her options are quite limited. Hey, man, you want to talk heroes in the IC movement? Donna Korn. Donna Korn, been running the IC Network Support Forum for 15, 16, 17 years. She's in her 80s now. She has a slow growing terminal cancer, but it's very, very slow. And she continues to support IC patients every single day in our forum because obviously I can't do everything anymore. I just can't. I'm usually on the phone with patients during the day rather than online. I like doing the one-on-one consults. Kara says, I know I have a high mast cell count from biopsies. Your treatment for this? Well, obviously, it's going to be an antihistamine. It's going to be probably hydroxyzine, also known as Atarax or Vistaril. Atarax is hydroxyzine hydrochloride. Vistaril is hydroxyzine pamoate. I will tell you between the two, Atarax, the hydroxyzine HCl is the cheapest one. It's the most common generic, and it is also the worst tolerated. It tends to be quite junky. I took one Atarax and I knew I could not take it. So I switched over to Vistaril and did much, much better with it. Vistaril is much better for me. And guys, listen, for anybody who's going to have a diagnostic hydrodistension, remember beforehand, you have to talk with your doctor and have a plan if they find Hunner's lesions. One of the great tragedies are patients who have a hydrodistension and then bam, they find lesions, but the doctor won't do anything about it. And I will say that in the vast majority of patients that I work with long-term chronic severe pain, it almost always comes back to lesions that were never treated properly, and it breaks my heart. So ask your doctor, okay, when you get in there, if you find a lesion, what are you going to do about it? What's your plan? What's your plan? And if he doesn't have a plan, I don't know if I would do it. Here, hold on. I'm fixing my light. I look terrible today. You can tell I didn't get a lot of sleep last night. I got bags under my eyes. Ooh, holy moly. Jennifer said he will hook wires to your bladder as a diagnostic test. If it works, they will do the permanent one. They don't hook the wires to your bladder. If you're talking about an interstim trial, what they do is they're hooking the wires to your nerves, either your pudendal nerve or your sacral nerves. But they don't hook wires directly to the bladder. Amelia says her surgery for IC was canceled till further notice. Yeah, that's what we're seeing. Hello, Jean from the UK. Thank you, Jean. You're very, very sweet. Amy says, wish you all the best. I'm in so much pain. I'm guessing stress from this new world is not helping. I'm on painkillers all day. I'm in Denver. So, guys, okay, so if you're in pain and you don't have access to pain medicine, you got to pay attention to a big research study that happened last year using something called palmitoethanolamide, PEA. PEA has been used in Europe for more than a decade for chronic pain. And we had our first PEA interstitial cystitis study released about a year ago at the American Urology Association, and the data was spectacularly good. The doctors who were there were very, very excited because PEA is extremely well tolerated. It is known for chronic pain, especially nerve-driven pain. And in this research study, uh, at 3 months, 87% of patients using it had a significant reduction in pain. At 6 months, every patient using it had a significant reduction in their pain, and 25% were pain free. And you can, if you go back on our website and look at our report of research from the American Urology Association, we went over that, or you go to my summer 2019 IC Optimist, we go over that research study in depth. Because PEA is not easily available, what was not, I mean, I knew about PEA a decade ago. We had a pharmacist in San Diego who was trying to import PEA for IC patients, but it was incredibly expensive. It's not expensive anymore. And um, when the study came out, an American company, Natural Approach Nutrition, I gave them the study and said, guys, look at this. It's supported by research. And so they created a US version of that research formula called PEA, Peora Poly 500. And it is remarkable. It is helping so many patients now. This is the supplement I take now if I'm starting to feel any nerve driven pain, because I tend to get a lot of very prickly pain. Um, and um, it's fabulous. And it's $29. Um, and we're going to do, because of COVID, um, we're going to make the next 1,000 bottles 24 bottles. I mean, $24. Drop the price $5 to try to make it really affordable. And I try to do some giveaways too. I'm going to try to do, once I get my next order, I'll be able to do some giveaways. So if you're struggling with pain, you don't have access to pain medicine, the research from Europe showing PEA is helpful for IC is solid, and it was presented at the American Urology Association. And so this is now available as Peora in the United States. And also Bladder Builder, the supplement Bladder Builder also contains PEA in it. And so there are some options if you're struggling with pain and your doctor won't help you with pain. Those are valid options. Kata says, I'm waiting for cystoscopy for months, but recently realized I have clitoral phimosis. Could that be cause urinary symptoms? Okay, I'm not sure. I got to look up phimosis. What does that mean? I've never heard that word before. Phimosis is defined as an inability to retract skin covering the head of the penis or the clitoris. I don't know, hun. It can go away over time with regular gentle retraction. It may look like a rubber band of skin. If complications develop, such as bleeding, infection, or painful urination, and I don't think that so, Kata, I don't believe that that's gonna change the bladder wall in any way, but what it is absolutely gonna do is if it's painful, it's gonna cause your pelvic floor muscles to get tight, and that would give you pelvic floor dysfunction. And of course, long-term pelvic floor dysfunction is gonna restrict blood flow to your bladder and result in your bladder wall breaking down. So, um, any the thing about pelvic pain and the failure of Western medicine with pelvic pain is that everybody focuses on their unique box. Urologists focus on the urinary tract, gynecologists focus on the reproductive tract, gastroenterologists focus on your gut. Nobody really looks at the muscle connection very, very well. Um, but if there's one thing we know about the pelvis is the tremendous interrelationships in the pelvis, and that muscles will change organs. Tight muscles will change the bladder, will change the vulva in a somatovisceral reflex, just as an organ can change a muscle in a viscerosomatic reflex. Kristen, I'm in severe pain, hips, legs, when standing in 5 minutes plus usual bladder. I'm pretty sure it's from stress because my family and many others are being affected by the virus. It's financial. Girl, you are so not alone. It's the best way to deal with pain caused by stress. You have to disconnect, hun. We all have to disconnect. Turn off the freaking TV, get off of social media, don't even look at the news. You have to do things that are nourishing to you. You know, if you can go outside, if you've got a garden, plant a victory garden, work in your garden, get in the sunshine, practice your deep breathing, practice your meditation. But, hun, the fact is that you're having severe hip and leg pain when you're standing tells me you got muscle stuff going on. And I would want to know why that your legs hurt with standing even for 5 minutes. Why are your hips hurting? Why are your legs hurting? Are you sitting too much? Are you laying down too much? Sitting is the new smoking. The longer we sit, the weaker our muscles get. It's important to be up and moving. But I hope that you've worked with somebody about your leg pain and your hip pain. You may have a bony abnormality. You may have hurt a joint. You may have hurt a ligament. Um, and they're all going to influence your pelvic pain. Amy says a 3-month schedule is new. I used to have it every 6 months, but the effects last less time. It takes you 2 to 3 weeks to fully recover. So this is, Amy, you need to try to subtype yourself here because, I mean, please come watch our video on subtyping so that you understand all of these unique variations, these that we are clearly found in the IC patient community. If, for example, your symptoms began after muscle injury, your hydrodistensions will never fix that. What will fix that is muscle therapy. So I would really hate for you to be locked into, you know, unnecessary OR trips for hydrodistensions, knowing that it might, a hydrodistension might help because it temporarily breaks the nerves, but the nerves come back, the nerves grow back, and sometimes more nerves grow back. The American Urology Association is really crystal clear. If a patient is not responding to therapy, if a patient is getting worse rather than better, y'all need to take a step back here and reconsider the diagnosis and ask ourselves, have we missed something? Amy, I have a huge list on our website of other conditions which can trigger the symptoms that we associate with interstitial cystitis. And you, of anybody, needs to go through this list and make sure that y'all haven't missed something because having a hydrodistension every 3 months is quite extreme. And so let's talk about some of these confusable conditions that can mimic the symptoms of IC. So let's go over these really quick. Okay. Um, Radiation cystitis. If you ever had radiation because of some sort of cancer, that would damage blood vessels and potentially damage the bladder. Do you have chemotherapy-induced cystitis from chemo? Was your cystitis triggered by the exposure to a toxin like teoprophenic acid, ketamine? Do you have a bladder neck obstruction? Do you have urinary retention from tight muscles? Do you have a neurogenic bladder from nerves that have been damaged? Is there any chance that you have bladder stones? Because bladder stones are quite common around the world. Do you have pudendal neuralgia? Do you have Charlotte cyst coming off of your spine? Was your bladder ever injured or perforated through surgery? Could you have a urethral diverticulum? This is very interesting. So I was working with a patient a couple years ago who, again, she did every bladder therapy. She wasn't getting better. Her pain was primarily urethral. And, she went from doctor to doctor to doctor. Nobody was really listening to her. And finally, a nurse practitioner listened to her and ordered an MRI of her urethra. And you know what she had? She had a urethral diverticulum. So your urethra is like the size of your little finger, right? Size and diameter of your little finger. She had two. There was a little tube that was connected to a separate tube, literally the length of your urethra, and it was filled with urine and it would not drain properly. And it was so odd. Women can get, men and women can get prolapse, especially women get prolapses from straining too hard. Well, she had the ultimate prolapse, only it was prolapse to the side and it was like a green bean that would not drain. And so they surgically removed her urethral diverticulum and she was cured. She was cured. For many women can have estrogen atrophy, urogenital prolapse, endometriosis, fibroid tumors, pelvic congestion syndrome. Pelvic congestion syndrome is basically varicose veins in your pelvis, large veins in your pelvis. We're doing an article on pelvic congestion syndrome in our next magazine. Stacy is finishing that up. Men might have chronic prostatitis, benign prostatic hyperplasia, prostate cancer. But but here's the most interesting confusable condition. And let me get my magazine. Where is it? Where is Oh, here it is. Okay. So I got a phone call like 2 years ago from a woman who, again, long term chronic IC, frequency, urgency. None of the therapies helped her. She was really suffering. But the thing that was so interesting is that people in her family were getting sick. Everybody in the family was sick. And they discovered a massive black mold problem in the pad for her carpet in her house. Apparently, her water heater or her refrigerator leaked. It leaked underneath the carpet, black mold everywhere. They found the black mold. She moved out. They treated the house. And what do you think happened? Her bladder healed. Healed. No more symptoms. And so I told this, and I shared this story because it was so interesting that I didn't know that black mold could trigger urinary frequency urgency. I had no clue. And so I assigned that research project to Stacy, and her the results of that, it was featured in our winter magazine. Could mold toxicity cause IC symptoms? And damn it, would you believe it? It does. It does. If you've got black mold in your house, if you've been exposed to black mold, you could have frequency, urgency, pressure, pain. And the good news about that is that when you treat the mold, the symptoms usually go away. So again, Amy, getting back to you and the fact that you're having hydrodistensions every 3 months, it's very, very important that we take the time to really thoughtfully rule out some of these other conditions, because I would really hate for you to, think of you say it takes 2 to 3 weeks for you to recover from each one. That's really changing your life. You've got the cost of it, the expense of it, the trauma of it. And it would be absolutely fascinating to find out if something else is involved. And remember, too, Dr. Weiss in this book, one of the points that he mentions here is, one of the things, so he was a urologist who changed his practice to myofascial work, right? Based in San Francisco. Brilliant, brilliant, brilliant doctor. And he was really the first to grasp the connection between the bladder and the muscles and the nerves and all of that. He's kind of like the lone voice in the crowd for many, many years. Um, so he became a master at figuring trigger points, at treating trigger points. If you had a trigger point in your pelvis, he could get rid of it. He became a master at calming nerves down. In fact, there's 2 chapters in here on how to calm nerves down and understanding why nerves get involved. But the thing that really puzzled him is, why did the trigger points recur? Why would patients flare? And when they flared and they would come back with the trigger point in the exact same location. And that really was the mystery, is why is it always on the left side for me? It's always on my left side. And so that made him take a step back and consider other structures. It's like, okay, if there is he calls it a mechanical dysfunction. If there is a mechanical dysfunction in your hips, the way your muscles move, in your legs, in your feet, again, if you got one leg longer than the other, or you're overpronating, or you're pigeon toed, or you have hip dysplasia, or you've got SI dysfunction, those all will absolutely influence the pelvic floor over time. And so, his chapter in here on the feet is stunning because when you think pelvic pain, man, you stay focused on the pelvis. You don't really think mechanics. But there can be legitimate mechanical reasons why your pelvic floor is always tight. And suspect number one is your hips. Suspect number two is going to be your knees. Suspect number three is going to be your feet. Because if you're not walking normally, if you've got one leg longer than the other, scoliosis, your hips are not level. You got a hip that's higher. You've got muscles that are strained, all sorts of funky things happening. And in the end, what he found in his practice is that 90% of his chronic pain patients who continue to flare and who had muscle issues as well as bladder issues, it all came down to their feet. There were problems with their feet. And his chapter on the feet is absolutely stunning. So here we go. Red flags that signal a problem: bunions on your great toe, hammer toes, plantar fasciitis, shin splints. And the pictures in here are staggeringly good, right? So here is a picture of somebody whose ankle falls inward. So here's a normal leg, and you can see the forces go straight up into your pelvis. Here's an ankle that goes inward, and you can see that the femur is pushed out farther. The piriformis muscle and the adductor muscles are stretched more, creating chronic dysfunction when that patient walks. That person walks. And so what he found is, so the case reports are fascinating in here. So let me read a couple of the case reports. So case number 2, a 65-year-old woman came to see me with a history of recurrent urinary urgency frequency and urethral pain without infection. Examination revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual therapy, to which she responded positively. However, she continued to have pain flares. While my treatments were effective in the short term, the results only endured for variable periods of time. I continued to administer periodic therapy for nearly 10 years. At the time of her last visit, armed with new knowledge, I looked at her feet and noted unusually high arches. When I asked her if she experienced any of the potential side effects, she came out with bilateral Achilles tendonitis, knee surgery, and more recently, hip pain when waking up or standing up from a crouching position. In my mind, I visualized a straight line of mechanical stresses. It began with a foot imbalance, which affected the Achilles tendons, then the knees and the hips, and ultimately the pelvic floor. A visit to the podiatrist was the last stop on her healing journey, and it is unlikely she will require many, if any, additional sessions with me. 10 years ago, when I first saw this patient, the feet seemed too distant from the pelvis to be considered in the treatment plan. Experience has now taught me otherwise. Right? Here's another case study. 50-year-old man who'd been seeing me occasionally over 10 years for intermittent perineal pain. I had been treating his tight pelvic floor muscles and trigger points with internal manual therapy. Though he received great relief from these treatments, pain flares inevitably occurred. Frankly, I had never completely understood the mechanics of his symptom flares until he came in one day complaining of hip pain while walking over hiking trails. This led me to question him further and ultimately put us on the right track. I asked if there were any other musculoskeletal problems that he had not thought to mention previously. He responded that he had always had pain at the base of his large toe, which he attributed to arthritis. But because he knew that other family members had the same problem, he never sought attention for it. I then examined his feet, something I had not been accustomed to doing, and found small bunions and moderate overpronation. At that moment, the light went on. I found the origin of his hip pain that he had experienced in hiking, as well as his intermittent perineal pain. Podiatric treatment, foot treatment, healed, has eliminated his flares, right? So anytime somebody has long-term chronic muscle tension, we always take a step back and we look at the mechanics of their body. We have to look at the mechanical influences of their body, their legs, their feet, their knees, et cetera, et cetera. Guys, hold on 1 second. I gotta look at something here real quick. Hold on. Give me one quick moment here. Give me a quick moment. All right. I still have not eaten anything today, and so I'm getting a little weak in the knees. I'm gonna have to stop soon. I made for dinner 2 nights ago macaroni and cheese with bacon, and that proved to be a little too fatty for my stomach. And so my stomach doesn't hurt anymore. But let's just say I'm going very very slowly, and I didn't want to eat before I did this in case my stomach decided to take a hair turn and start hurting. Curtis says, I'm, su- I'm subtype bladder while driven. I have a dextro curvature of the spine and kyphosis. I get a lot of mid back pain during the day. I've got pelvic floor exam soon. Good, dude. I'm really glad you're going to do that. And it's hard because you and I have scoliosis. I mean, I think your scoliosis is probably more intense than mine. And so it's not like we can change that, but at least it explains it and it will help you target what you need to do with those muscles. Because, with scoliosis, you've got a curve in your back, right? And so the muscles on the outside are overstretched and the muscles on the inside of the curve are contracted. And if you have an S curve like I do, like you can't tell I have scoliosis. I'm supposed to be an inch taller, but I have an S curve in my back. And um, it might help you with some more proactive muscle work. Curtis says, I have trouble starting stream and completely emptying the bladder. Takes a long time. Yeah, so anytime you cannot start your urine stream right away or it's slow, remember urination is about relaxation. A muscle relaxes, a sphincter opens, and you pee. And it's normally bam, like that. But if your muscles are tight, it can take 5, 10, 15, 20, 30, 40 seconds, a minute, 2 minutes before you can relax your muscles enough to empty your bladder. That's a classic symptom of somebody with tight pelvic floor muscles. So, Curtis, I would bet you big money that you've got pretty significant pelvic floor dysfunction. And the good news here is now you can work on it. A muscle therapy helps. It's for guys, admittedly, it's challenging because they have to do it rectally, and you might need to use a wand rectally, but understand that that's the best way to access those muscles, and it pays off in the end. It pays off really, really well. But again, Curtis, this book is a must for you so that you can understand uh, the relationship the muscles are playing with where your pain is presenting. You are an anatomical mystery to be solved. The book is free on Kindle Unlimited. If you've got regular Kindle, it's $9. If you want the paper version, it's $36 on Amazon. It's 28, something like that, on our website. If you the cheapest, it's a big heavy book, guys. Listen, it weighs like 2 pounds. So shipping is freaking expensive. If you want, it exceeds first class. So your only choice is media mail, which can take 2 to 3 weeks, or priority mail, which is going to take 3 to 4 days. Priority mail, don't be surprised. It could be anywhere from $8 to $12, depending upon where you are in the country. I'm telling you, it's worth every penny. It's worth every penny. Lauren says, does anybody else use Urabel for flares? We were just talking about that yesterday. Again, usually not long-term use. It's really just about do what your doctor tells you to do with the Urabel. Amelia says my insurance won't cover pyradium. Well, it doesn't need to because it's available over the counter as azo bladder pain relief tablets, Amelia. That's why insurance companies don't cover it, is because it's over the counter and it's very inexpensive. So it's okay. Just look for azo bladder pain relief tablets. We have it in our store. You can get them at Walgreens, at CVS, grocery stores carry it, and Walgreens and stuff. They have their own brand name for it, but it's really quite inexpensive. You should be able to get it for under $10. Sarah says, "How would I deal with somebody in your support group that you believe is pretending to have IC?" Well, Sarah, again, you've got to understand subtypes. Your IC might be very different than their IC. You know, you might have very obvious IC where they might have central sensitization and a sensitive nervous system. So you have to understand, number one, that not everybody's the same. Symptoms can be wildly different between patients. Their history can be wildly different. Um, and so I wouldn't, I guess this is what I would do as a support group leader. Number one, I would, if somebody's coming off as a little shaky to me, I would pull them aside and I would have a talk with them, especially if they're making kind of outrageous claims. We have had in our support groups, any number. It's really really rare that I would ever ban somebody from the IC network, but I have banned people from the IC network, usually for how they treat other people or how they have talked about it. I had one patient come on to the IC network who told every patient they should have an abortion, which is stupid. Many IC patients, most IC patients are great parents and they have wonderful children, and it's just not an issue. But there are some people that can be a little mentally off, and or mentally ill, or somebody giving really reckless advice. Let me just say too here that you have to understand that mental illness presents in many many different forms. There have been some top IC leaders who have been significantly mentally ill, even doctors. We had a fabulous doctor who, was, you know, it was very sad. He ended up taking his life. Mental illness happens. Mental illness is compounded by chronic illness and chronic pain. And so it's going to be magnified sometimes in support group settings. Also understand too, Sarah, that running a support group is challenging because you've got two distinct groups that you try to please, but putting them together in the same room or the same Facebook group is really, really hard. You've got newly diagnosed patients who need the facts, they need the information, they need the encouragement, they need to know that they're not alone. And you want them to leave empowered, excited, informed, and ready to conquer the day. And then you've got a smaller group of patients who are sincerely and legitimately in crisis and chronically struggling. These are the patients with untreated Hunner's lesions. These are the patients with, you know, um, uh, it got so many shoot through my head. It's almost hard to describe. Patients with surgical injury, patients with, you know, who have been mistreated, who have been maltreated, who, you know, and when they come into the room, they they need support too, but their stories can be quite frightening and quite discouraging. And again, this is where subtyping matters. Rule number one in any support group is you have to tell patients that one patient's story is not their story. Each patient represents an anatomical mystery to be solved. And a newly diagnosed patient cannot come into this group and read the story of somebody who's had a viral infection for 30 years, who's never gotten the right treatment, whose bladder is now shrunken and facing bladder removal. Okay, that's not that newly diagnosed patient's journey in any way, shape, or form. That is very, very rare. But when that patient comes onto your group and vents and cries and tells their story, and they're angry and they're bitter and they're sad and they need support over and over and over and over and over again, and it's legitimate, they really need that support. But damn, it's scary for that newly diagnosed patient. So again, rule number one is every patient is unique. Rule number two, one patient's story is not their story. Rule number three is you are on a journey. It is your journey. You, as a newly diagnosed patient, understand subtyping. Every patient is unique. We've got to figure out what your unique presentation is. And when or if the internet scares you, get the hell off. If you are fragile, if you are depressed, if you are crying all the time, the last place we want you is on the internet. You know, no, there is no substitute for face to face hugs, face to face support. And if you've got somebody who's in an emotional crisis, it is important that you refer them back to their doctor and to an expert who can help them through that crisis, because none of us can do that. You know, they need a hand, they need eyeballs on the organ, they need somebody studying their body, and they need somebody giving them emotional support for that patient in crisis. Now, remember too that what the research shows, and this is very, very true, that within 6 months of diagnosis, most patients stabilize and then they improve slowly, but they usually improve. And I would say that that's even better now that we have subtyping, because now, you know, 20 years ago, we didn't know about the muscles. 20 years ago, all these muscle patients were put on bladder therapies that didn't do a damn thing for them, and they got much worse. Today, with subtyping, we can turn patients around really quickly and get them better. Okay, so if you're going to be diagnosed with IC, to be diagnosed with IC in 2020 is absolute blessing compared to being diagnosed with IC when I was diagnosed in 1993 or earlier. Okay, so I hope that that kind of helps. Um, and know too that I'm available to speak. If you have a real in-person meeting, I frequently do Skype with your support groups, and we'll take questions from your support group. Brittany, my urologist thinks I have a tight pelvic floor causing my pain. Haven't seen a physical therapist in person yet. I'm sensitive to things like alcohol and coffee. So could be pelvic floor. Yeah, because again, it's called the somatovisceral reflex. It's called the somatovisceral reflex. What that means is that muscles, dysfunctional, damaged muscles, restrict blood flow to the bladder. It's very hard for the bladder to be healthy when it doesn't get good oxygenation and or nutrition. But the other thing that Dr. Weiss explains so well in this book is the toll of long-term trigger points and compression of nerves. So a nerve fiber is a long, skinny fiber, and you would think that there would be one nerve in that fiber, but there's not. There's a nerve going one direction and a nerve coming the other direction, and there's usually a little blood vessel to support it. Little tiny capillary. Now, if you fall, bam, you fall on your butt. What does that do? That's an immediate compression injury. So, and we know blood vessels can be damaged with a fall because you get a bruise. But let's think for a moment about what a compression injury does to a nerve, because you've got nerves in and amongst those muscles. So, or if you have a trigger point squeezing a nerve. So the nerve is flattened. The nerve fibers are flattened. The capillary inside the nerve is broken. It is flattened and broken. But unfortunately, because it's confined in the nerve fiber, it becomes a compression injury. So you've got blood leaking into the nerve fiber, filling up the space, stretching the nerve, damaging the nerve. Now, I'm going to get really geeky here and explain this for a moment. The way a nerve fiber works it is with a migration of um, sodium, sodium, I want to say potassium, and it's not an electrical impulse. It's a quick migration of chemicals inside and outside of that nerve fiber. It's fascinating the way it does. So you've got a section of nerve fiber, and then it ends, and you've got a synapse, and that's a gap. And the nerve fiber releases a neurotransmitter, usually acetylcholine, which then jumps the gap over to the next nerve fiber, where it then causes the chemical interaction to go. When a nerve fires, it releases calcium. And then that calcium has to be reabsorbed for that nerve to work correctly again. The calcium is reabsorbed by a healthy nerve that has good blood flow. But if the blood flow is damaged, the nerve cannot reabsorb the calcium. So the nerve becomes a sick nerve. That nerve cannot function normally. The nerve is broken, and he calls it a sick nerve. So what happens is those sick nerves, that neurodysfunction moves up to the spinal cord, where it then begins to affect the nerves that are also in the spinal cord, including the bladder nerves. And then the bladder nerves become dysfunctional. And eventually that dysfunction moves back down into the bladder wall. And a dysfunctional nerve, a damaged nerve, releases something called substance P, which destroys tissue. And that's what causes the tissue of the bladder wall to break down. So that's the second way that something outside of the bladder can damage the bladder wall. So what's the treatment for that? The treatment for that, we have to go all the way back to the nerve injury and the muscle injury, and it's about restoring blood flow. We've got to get those muscles long and loose and pliant and create a situation where blood flow is improved so that hopefully nerves have an opportunity to heal and for those blood vessels to be repaired. And that becomes the foundation for the recovery of the bladder wall. So it's very complex, but again, it is called a somatovisceral reflex. Muscles can change the bladder, nerves can change the bladder, just as the bladder can change muscles, vice versa. So, yes, you need to get your pelvic floor checked and work on it. If it's tight, work on it. Listen, you could do every bladder treatment in the book and calm your bladder down, but as long as your muscles are tight, you're screwed because tight muscles damage tissue. You have to do both. You got to protect your bladder and work on the muscles. And that is why pelvic floor patients are diet sensitive. It's because their pelvic floor has compromised their bladder wall. Yeah, you're still going to have to follow the diet when you're doing pelvic floor physical therapy, but hopefully by doing both, by protecting your bladder and working on those muscles, eventually you will get to the point where your symptoms have improved. Amelia says, I have endometriosis and I see, and the pain is excruciating. So girl, so you're not saying where the pain is. Endometriosis is really well known to attach to the bladder wall, as well as to move through the bladder wall into the bladder itself. And so um, normally they would be doing a sonogram to try to track your endometriosis a little bit. That's fairly vague. They would perhaps want to do a laparoscopy. I had a laparoscopy in September 1993 to rule out endometriosis, to give them an opportunity to visualize the tissue there, visualize where the endometriosis is. Endometriosis tissue can be very tough and stiff, and it moves throughout the pelvis. It can move all the way up through into your abdomen. And so normally, if your endo is kind of out of control, they've got to go in and try to release any restrictions if it's wrapped around your bowel, if it's wrapped around your bladder or on your bladder. You would at some point in time probably have a laparotomy to address it, as well as some hormone therapy. Also, Amelia, the Endometriosis Association in the United States is absolutely fabulous. I did a big story on endometriosis as a related condition quite a while ago, 8 or 9 years ago, where I interviewed the founder of the Endometriosis Association, and she was absolutely amazing. I mean, it's so interesting that the IC community and the endometriosis community both got started in the 80s. They got started before, I didn't get involved until the early 90s, but they took really different approaches. So the endometriosis community had a massive breakthrough early on. And I'll tell you, it's absolutely fascinating. So I'll tell you what happened. Um, I don't know if you know what dioxin is, but dioxin is the most toxic chemical ever invented by man, and it occurs when you burn plastic. When you burn plastic, dioxin is released into the air. It gets distributed into the environment. It collects in soil. It then collects in grass. Then the cows that eat the grass end up with dioxin, and then the milk that the cows produce ends up being contaminated by dioxin, right? So dioxin researchers, the plastic industry, was trying to prove that dioxin was safe so that they could justify their industry. And they were doing animal studies. They were doing studies with monkeys. And in this small study, they had a monkey die, and they did a necropsy, and they found that this monkey was filled with endometriosis. And then they had another die, and that one was filled with endometriosis. And these were monkeys that were given various levels of dioxin. So they suspended the study and they published a paper in this little chemical safety journal saying dioxin triggered endometriosis. Now, we would never have found it, but those endometriosis volunteers were persistent and they looked at everything and they found this little tiny journal article. And they went, holy crap, wait a second. Are you saying that dioxin exposure causes endometriosis? And they discovered that they were either going to kill the monkeys or sell the monkeys off. There was no doubt that dioxin triggered endometriosis at that point in time. So they went in, they petitioned the National Institutes of Health to do laparotomies on these living monkeys to confirm this. And what they discovered was a dose response, that the more dioxin these monkeys were exposed to, the greater the endometriosis. And so that was a pivotal moment in the evolution of our understanding of endometriosis. The endometriosis is, in fact, pretty much a man made disease. And it makes sense because you go back to World War II and you look at the literature, and there were maybe 10,000 cases. Today, there are millions of cases around the world of endometriosis. Why? Because of the mass proliferation of quite toxic chemicals. And about every year now, a new chemical has been linked to endometriosis. So, number one, Amelia, this is not your fault. You should not carry shame or blame in any way. Number two, uh, what the Endometriosis Association really emphasizes is removing chemicals from your home and from your daily life. And when I interviewed her 10 years ago, that was critical. She's, you got to get rid of all the chemicals in your home. No Febreze, no scented candles, no oven cleaner, nothing like that. No fancy laundry detergent with chemicals in it. I was buying this natural dish soap that I thought was perfect. And my dad's hands turned really red. And there was one ingredient in there. I looked it up. Holy hell, it was a bad toxin. And yet they said it was green, and it's not green. I oh my god, I was so angry that I found it. So it's all about going back to nature, using vegetable sources and plant sources for cleaning. Um, so I would encourage you to go to Google Endometriosis Association and look at their materials. Their materials are truly excellent. One gift that the endometriosis community gave us is Procerona and NeuroQuell, and I think I have it here. Let me see if I can find it. Where is it? Where is it? Okay. So it's an essential oil that they helped to develop. Procerona. Oh God, I just. Oh, wait. I just spilled my water glass on my keyboard. Ah, on my book. I knew that was going to happen today. See, you know it's not a real support group meeting from Jill Osborne if something like that doesn't happen. Here, hold on. Okay. Hold on. No. I knew I shouldn't have had that glass there. All right. All right. All right. So, Procerona and NeuroQuell they were something that the Endometriosis Association turned me onto. It's the essential oil of the calendula plant, and what you do is you rub it on your skin, and it's particularly good at disrupting pain messages. And so uh, they were the ones who worked with the company to develop it. We sell it in our store. It's a little small vial of oil that you can rub on your belly. Now, what they did is they gave me, I called the company that makes it for them and said, have you studied with this with IC? They said, no. I said, well, I've got a population of IC patients. Would you give me some and let's just pass them out and let's do a small study? And we did. So we did a very small study of like, I don't know, like 25 patients. And we just gave them Procerona to try. And 33% of patients said it significantly improved their pain or eliminated their pain. 33% said it was slightly helpful, and 33% said it didn't do anything. So, again, given the fact that so many patients are being thrown off their pain medicine, having something that can help their pain is important. And these little essential oils, I'd never heard of it, but they were the ones who helped to invent it, and it worked really well. So you can get that on our shop too. Cara said, I had a hysterectomy and removed endometriosis, including endometriosis on your bladder, but the surgery made your IC worse. So Cara, Cara, now let's think about this for a moment. Again, I want you to think about it from the perspective of what could be triggering your pain. Is it muscle, or is it your bladder, or is it nerve? So when you have surgery, that's a trauma. So they went in to remove the endo, which is exactly what they needed to do. We knew that needed to happen. Okay. But when they do surgery, they cut muscle and they irritate nerves and potentially cut nerves. So the reason why you might be feeling worse after having the surgery is just from the trauma from the surgery itself. Um, that's concept number one. Concept number two is if you had it on your bladder, did they accidentally perforate your bladder? I had one patient that I worked with who that happened to. She had surgery. A stitch accidentally went through her bladder wall. It was a permanent stitch. And, a year later, here her IC symptoms were terrible. They went in and they looked and they found the stitch in her bladder wall and they removed it and her symptoms went away. So I completely respect the fact that it made you worse because my hysterectomy absolutely made my pain worse for months. It was terrible. But the reason why I was worse after my hysterectomy was because I was having involuntary muscle spasms from the pain, and physical therapy helped fix that. DJ, okay, DJ had a hysterectomy at 33. So Lauren says, my Da Vinci assisted partial hysterectomy done to remove uterus, endo, and adhesions was what triggered your IC, damaged your pudendal nerve badly on both sides, but IC runs in my family too. I think I had it for a while. I always thought that I had UTIs and they came back negative almost every time. No doctor ever questioned. Okay. So again, so Lauren, you know, it's so important to try to be a little bit more specific in that. You say IC runs in your family. So what runs in your family is central sensitization. Okay, so we know you have sensitive nerves. Okay, and that's fine. Um, um, you are a surgical injury patient. You're a surgical injury patient. You had surgery, he damaged a nerve, and so, you know, I'm going to say that, like in 10 years, when they really refine subtyping, I don't think you would ever be I don't think you would be diagnosed with IC. I think you would be diagnosed with pudendal neuropathy. I don't even think they would say IC again in your case. I think you really are a central sensitization that is your landscape. You are sensitive. Your whole body is sensitive, just like your family members are sensitive, just like mine. We can go back generations in my family. Okay, that's the landscape. But ultimately, in the end, you had endometriosis. They went in and did surgery, and they damaged a nerve. You are a surgical injury patient. And so therapeutically, you're going to be doing things that are specifically designed to calm nerves down. I mean, like, I think Piora would be so important for you to try, because what the research showed with PEA is that it was most successful at reducing nerve pain, right? And so that would be absolutely fascinating to try and see if that made a difference for you. Along with maybe gabapentin, things that will calm nerves down, doing lidocaine on your skin. And again, he talks about surgical injury in this. One of the things that Dr. Weiss did in his practice is he did some sub-Q infusions of lidocaine. So in part of his diagnostic workup with pelvic pain patients is he looked at the skin, because he wanted to see if nerves were damaged. And if nerves are damaged, skin tends to be sensitive. Or if you touch the subcutaneous tissue under the skin is quite sensitive to touch. And he was able to calm those nerve groups uh, down by doing lidocaine on the skin and or sub-Q lidocaine underneath the skin. Deborah says, when I get kidney stones removed, my second urologist does not leave the stent in because it's the most horrid, painful thing I've ever had. Girl, oh, I totally agree. Oh, I've had a couple of patients who have been given uh, stents, and they will inexplicably, you are crying in pain, take it out, and they won't take it out, even if you don't need it anymore. It's crazy how painful urethral stent, I mean, um, your ureteral stents can be. It's not a urethra, it's a ureteral stent. It's a stent in the ureter designed to open up the ureter so that a stone can pass through more easily. Or if the ureter has been damaged and is narrowed, it opens it. Cara says, I believe I still have endo on my bladder, but foods and drinks really amp up my IC. Well, and that's absolutely possible. That's absolutely possible. And so, and the other thing y'all got to remember here is that our ability to tolerate certain foods changes as we get older anyway. When you're young, you got a lot of mucus, you got a lot of estrogen, your tissues are resilient, you're not going to feel as much. as if you're in 30s and 40s. And one of the things Dr. Weiss says in his book is that it's in your 30s that you start seeing the toll of what word did he use, like wear and tear injuries, that you might not feel something when you're a teenager or your 20s, but in your 30s, your late 30s specifically, that's when you start seeing more wear and tear on the pelvic floor and on the pelvis in general. Handling, cooking, and eating chicken are implicated in E. coli infections. Absolutely. Got to be really careful. And actually, what they say too is don't rinse off chicken in your sink because you're basically spreading it even more. You know, Deborah says, at times my urethra is painful. Why did my doctor, Dr. Parsons, prescribe potassium 3 times a day? I'm scared. What? Are you sure he prescribed you potassium? Because he is the no potassium guy. I mean, normally you would only take potassium if you've got an electrolyte imbalance. He is the absolute no potassium. He invented the potassium sensitivity test to specifically diagnose an injured bladder wall. That's baffling to me. I don't understand why he would say that. Deborah, I think you need to talk to your regular doctor about or do you have the exact name of the medication he gave you? Can you give us the exact name of the medication? Zoe says, I don't have a UTI, but I have chronic urethral pain. I don't know where to go from here besides getting answers and treatment besides analgesics. Zoe, I have a fabulous blog on our website. You just go to icnetwork.org. It's called The 7 Causes of Urethral Pain. So here, let me grab it and let's just go through it real quick. Ooh. Okay, hold on a sec. So I've just gone over to our website and I typed into the search area urethral pain. And here's the article, 7 causes of urethral pain and urethritis. So let's just go through this real quick, okay? So number 1. So first of all, let's just all make it perfectly clear. Everybody knows what the urethra is. So the urinary tract has 4 distinct structures, your kidneys, and it's your kidneys that filter toxins and water out of your bloodstream and send it down your ureters, which are 2 tubes which go side by side, which then enter your bladder. So your bladder's kind of shaped like a heart. You got a ureter hole here, ureter hole here. The urine drains out there. It collects in your urine. And then the last piece of the puzzle is what you pee through, which is your urethra. In a man, your urethra is like 5 inches long. In a woman, your urethra is like 2 inches long, the size of your little finger, not with your nail. And so what we're asking now is what causes the urethra specifically to hurt? Number 1, catheterization. Anytime you have a procedure where they put a device up your urethra is not going to be happy. So whether you're being catheterized or you're having an examination, a cystoscopy, or they're giving you a bladder treatment, understand that putting something through your urethra is traumatizing. Um, Rule number 1 is if it's a catheter or a medical device, it needs to be slippery. So it is usually coated with KY jelly, or it's called a hydrophilic catheter. A hydrophilic catheter is a wet catheter. It's moist. You can slide it in and you can slide it out. Dry anything, putting anything dry into your urethra is going to hurt like but whether it's a red rubber catheter or a dry a dry catheter or a dry sound. They call it a sound, a little device that they would use for urethral dilation. That would hurt. I will tell you that generally that goes away within 24 to 48 hours. Um, uh, know that usually the first time that you pee after a procedure like that, it's going to hurt like hell because the urethra is tender. Uh, kind of a master uh, by how you approach that. So, what I eventually learned to do is to drink a very large glass of water afterwards. And then when it was time for me to pee, I just bit my lip and let it rip. It's the stopping and starting and stopping and starting that ow, 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 ow that makes it much longer. Sometimes you just got to bite your lip and let it rip. And if you can get through that 30 seconds, you're fine. Okay. Okay. The second cause, there you go. It is what it is. Second thing we're going to look at is bladder infection. Because bladder infections, that the bacteria not only affect the bladder but the urethra. But one of the really differentiating facts between a typical quote IC flare and a bladder infection is most IC flares don't necessarily make the urethra hurt, whereas bladder infections almost always will make the urethra hurt. Number three, hormones. If you are of a certain age or you've had a hysterectomy and you no longer have your ovaries, or if you are in your 40s and you are entering perimenopause, it's important to understand that your urethra depends on estrogen to produce mucus. And the urethra is kind of like the canary in the coal mine in terms of the urinary tract. It's the first part of the urinary tract to react to the loss of estrogen. And so it's that bottom half of the urethra that really starts to screaming when things start to dry out. So estrogen atrophy in the urethra feels like there's a drop of urine stuck in your urethra that won't come out. That's exactly what it feels like. Um, and it happened to me for 3 months when I was 52. And I threw everything I knew at it for 3 months. Didn't work. Finally went to my urologist. Said, "Please tell me what the hell is going on with my urethra." And I got a lecture on hormones. He'd given me my estrogen cream the year earlier. I hadn't used it because of my brain. I'm 25 years old. I can't imagine having an age-related issue. And it turned out I did need it. And the fix for that was rubbing a pea-sized drop of estrogen cream at the entrance to the urethra. And it's very, very common. Number four, an infection of the periurethral gland in a woman. We have a prostate. It's a female prostate, and like the male prostate, it is easily um, what's the right word for it? It gets blocked and stagnant. So about halfway up the urethral gland is a gland on the outside of the urethra that is kind of like a sea sponge, and it has little tiny drainage ducts that go into the urethra. And if any of those drainage ducts get blocked, that gland gets infected and it cannot drain. And it's basically the equivalent of a deep pimple. But you can figure out if you've got an infection because sex would be painful. Or you can stick your finger in your vagina and just about an inch and rub the front part of your vagina. And if you feel a, a, a small tender lump like a deep pimple, that is an infection of your periurethral gland. And what they would normally do is drain it. And they drain it by the way they drain a male prostate with massage. So they generally stick a little thing up your urethra and they have a finger in your vagina and they push on it and try to mush it out, try to mush it down into the urethra. Not the funnest thing in the world to go through. The next thing that we would look at for urethral irritation is pelvic floor tension, specifically of the urethral diaphragm muscles. And again, this book, Ending Chronic Pelvic Pain, gives a perfect discussion of why those muscles affect the urethra and cause urinary frequency urgency. And so, having a pelvic floor assessment to see if your muscles are tight is important. The next thing we look at with the urethra is chemical irritation, because a lot of the chemicals that touch our skin are actually irritating. Irish Spring soap, a heavily perfumed soap, body washes that have heavy perfumes are really well known to not only irritate the vulva but irritate the urethra. And removing some of those chemicals is very, very important. I always recommend Basis soap for sensitive skin, for any soap used down there. If you've never seen this, it's a Basis soap sensitive skin bar. And this soap and or an unscented Dove would be the only two soaps we would recommend. However, in this book, the Vagina Bible by Jen Gunter, which is also a breathtakingly good book, she has a wonderful section in here on soaps and what she recommends. And she goes so far. I mean, so that would be the other thing to look at here. And the last thing that we want to look at for the urethra is something that a lot of people don't necessarily understand, and that is off gassing from panty liners and pads. You have to remember, if you wear mini pads or use pads for your period, that the reason why they're thin now is that they have a chemical layer in there that absorbs water. And when it absorbs the water, it off gases chemicals that can be irritating. So many doctors, OBGYNs, have seen eczema on the skin, the shape of a mini pad, directly related to irritation from chemicals. So if you're going to use a mini pad, you want to do a chlorine-free mini pad, like Nature Care mini pads. I actually stopped using all mini pads last year, and my skin is so much better. So there you go. Over on the website, 7 causes of urethral pain. Interesting, right, Zoe? I love the name Zoe, by the way. I had a really good friend in elementary school whose name was Zoe. I think it's a wonderful name. Jennifer says, anybody see an integrative medicine doctor? Yeah, lots of patients have. Zoe, how safe is Elmeron for under a year? It is only Zoe, I will tell you that what the research studies show is that it's the quantity that you've exposed to over time. I was working with a young man who was taking 6 Elmeron a day, and he'd done that for 3 years, and he had been exposed to the equivalent of, 6 years worth of medicine. And in that MRI study, a patient who'd used it for 6 years had the worst damage of all. In our survey, we had patients reporting changes in their vision in the first year. It wasn't a lot, but some did. And in the clinical trial that led to the approval of it, we saw they absolutely showed eye damage within the first 4 years. So at this point in time, I think that Elmeron's kind of dead in the water. I think that it would be very, very important to uh, try a supplement that contains chondroitin first, and that's something that the American Urology Association encourages anyway in their treatment plan. Elmeron is a step 2 treatment. Supplements are in step 1. Why? Because the supplements don't have the same risk of side effects as a traditional medicine. Kristen says, "We're glad she refused Elmeron. You have enough eye problems." Yeah. Holly says, "My vision issue started after being off Elmeron for a year." Yep. God, you know what? I think I am way behind in these Facebook messages. I am sorry, hun. Amy says I look great. Thank you. You should see me this morning. Amy says she would love to know more about InterStem. I don't know if Amy's still in here, guys. I'm always way behind in these messages on Facebook. We have a whole section on our website on InterStem. If you'd like to talk about it, give me a phone call if you're still there. I have the most experience in the nation working with patients who have done InterStem, particularly InterStem complications. We have a lot of complications. There are hundreds and hundreds and hundreds and hundreds and more hundreds of severe adverse effects filed with the FDA over InterStim, including death. The last time I counted, there were 20 fatalities associated with InterStim. The most common adverse event with InterStim is deep tissue MRSA infections. Most patients pondering neuromodulation would do the ankle stimulation first, the urgent PC first, because there are hardly any side effects associated with that. That's what I did. It's cheaper, it doesn't require surgery. And so there you go. Jean says, can you get PEA in the UK? Yeah, PEA is very common in Europe. You should be able to get it from the European Union fairly easily. I mean, just palmitoethanolamide. It's a combination of palmitoethanolamide and resveratrol. Called UMPE. In Europe, it's called UMPE, UMPEA. I don't know if you can get it in England, but I would hope you could. Maria says, I've taken Elmeron for 2 years and now I'm so scared I need to stop. I don't want to develop eye problems. Lori says, where can you buy PEA? You can buy it from our store, IC Network. Amy says, I do have a serious eating disorder. I wonder if my colon is damaged and it's impacting my bladder. Can you and I communicate? Absolutely, hon. Give me a phone call. Give me a phone call next week or tomorrow. I'm a little slow on Mondays, just so you know, and I'm working late these days. I'm basically working from like noon to 8. Billy says, what do I think about Botox injections for the bladder wall? Botox is in step 4 of the IC treatment protocol. It's a step 4 because it does present with some fairly significant risks of adverse events, most specifically urinary retention. If they accidentally silence the nerve that controls urination, you will not be able to pee. Period. You will not be able to pee and you will need to self-cath for a period of time. There has been discussion more recently that Botox is more successful in the pelvic floor muscles than in the bladder wall. I don't remember exactly where I saw that discussion. I was in the last month in somewhere in a journal or something that I was reading. Where can you go for pelvic floor physical therapy? To a physical therapist trained in the pelvic floor. Hi, David. Kim says you're absolutely right about removing all the chemicals for life when having endo. Yeah, Kim, this is why what's happening with the Environmental Protection Agency is just stunningly devastating because our current president is now allowing more chemicals to be released. They've removed some of these safety parameters. And it's a great tragedy because we are going to see an increase in endo because of that. So Pamela has a very interesting story. She has lichen sclerosis. She just had a vulvar biopsy. She has IC, bladder, vulvodynia, fibro, pudendal nerve blocks, made me worse, arthritis in your hips and pelvis. You can't be touched. Your vagina hurts. So does your vagina hurt because it's dry? Normally, when we see somebody with extreme vaginal discomfort, it's often because it's a very, very dry, or your muscles are very, very tight. Your nurse practitioner, your doctor said it was prolapse. A Louisville doctor did a biopsy, and okay, and a prolapse is a prolapse. You did not have this until after pudendal nerve blocks. No sitting for. Okay, so your case is a little confusing to me. He said something about reconstructing of the vulva. Hmm. I would love to talk with you, Pamela. If you could give me a phone call this week on, you know, this book has a whole chapter on vulvodynia, and they have been able to in many cases, cure vulvodynia with pelvic floor work. That it turns out the vulva is just as impacted by tight muscles and nerves and pelvic injuries as the bladder can be. He also talks about persistent genital arousal in here. Anal, perineal, tailbone, orgasmic pain. I would just want to make sure that you have had a comprehensive pelvic evaluation. I think that's critical. Yeah, here's a whole chapter on vulvodynia. So vulvodynia's 6 key links. Number 1, dysfunctional pelvic floor muscles. Number 2, pudendal neuralgia. Number 3, subcutaneous tissue sensitivity and restriction. Sub 4, vulvar tissue sensitivity. Number 5, stress. Number 6, central sensitization. Uh, I had vulvodynia when I was in my 20s. Really bad vulvodynia. It felt like somebody rubbing my vulva with sandpaper every day. I mean, I could barely wear pants. And in hindsight, now that I know about my subtype and I know that my subtype is muscle and nerve driven, I now realize my vulvodynia was also triggered by that. So, if you want to give me a phone call, I just go to our website and the phone number's right on our contact page. It's on our Facebook page, also 1-800-928-7496. Just do either the corporate extension or the patient support line, and I will call you back when I can. I used to be examined without screaming off the table. Well, and again, you could be a vaginismus patient. I mean, many of the women that I've worked with have such extreme vaginismus that that's what they do. They cannot have their annual pelvic exam. All right, let's go back here. All right, my friends. Well, listen, we've gone for 3 hours. That's actually an hour longer than I thought we would because I still haven't eaten today and I need to go eat. So let's give you, let me, I do have a giveaway for people who have left. I mean, for people who are still here. Anybody want a bottle of Sister Protect? They gave me some bottles as giveaways. Anybody interested in receiving a free bottle of Sister Protect? I have got 2 to give away. So let us give you, I'm going to give you a question. And, I always, I don't make them easy. We'll see if you, so hold on. So let's see. We've got to come up with a good question. What would be a good question for the giveaway? Let's see. What would be a good question? Okay. Okay. So if you were paying attention in the last 15 minutes, you would know the answer to this question. What substance can you put in the bladder that would tell you if your bladder wall is damaged? It's a blank sensitivity test. I'm going to give 1 bottle Facebook, 1 bottle YouTube. So somebody was prescribed this substance 3 times a day, which makes no sense. So and it is an electrolyte. And there is a test called the blank sensitivity test. Allison just got it on Facebook. Allison Acton, you get a bottle of Sister Protect. Okay, so on YouTube, nobody's answered the question yet. I'm going to tell you that the periodic table letter for it is the letter K. Sherry Diggs. Sherry Diggs got it. Potassium. Potassium. So Allison Acton and Sherry Diggs. You each get a bottle of Cystro Protect, and I will try to send it out to you tomorrow. Hopefully, I've got plastic bags for it because I do not want to go to the UPS store. Also, Sandra Ciardelli. If anybody knows Sandra, she won a couple weeks ago a Breaking Through Chronic Pelvic Pain book, but I never got her mailing address. So if anybody knows Sandra, can you please tell her that I still have a book for her if she wants it? Otherwise, we'll give that away in another week or so. All right, guys. Well, listen, time for your homework. For 15 minutes a day, I need you to do something for your spirit and soul, especially now because COVID is making us all just a little bit crazy. Am I right? The stress right now is so hard. This is this is bigger than 9/11. We are really in a world war against a virus right now, and it is so incredibly serious. Here in California, we are seeing it's affecting our food supply now. For those of you who shop at Safeway, the Safeway distribution center for all of Northern California and Hawaii was closed because 5% of their employees have COVID. And so our shelves are starting to get a little thin, and that's pretty freaky. Make sure that every single day you do something that gives you comfort, whether it is reading, talking with a friend, listening to a service, going to a virtual church, or whatever. Do something to give you comfort because you deserve it. And I think it's really important to reward yourself. This is the time. I think that if having an extra cookie or two makes you feel better, you go for it. This is the time for comfort food, or in my case, comfort cinnamon rolls, which I love. And I have no shame. Yes, I have what do you call it when you have you wear leggings and your fat goes over the top a little bit? Yeah, I have those right now, and that's okay. I don't mind. I need you to do 15 minutes a day. I need you to do something for your bladder, your pelvic floor. Do your work, hon. Follow the diet. Do what you need. Spend 15 minutes working on your body. I need you to spend 15 minutes working on your noggin. You've done it for today because you came here to support group meeting. And last but not least, I need you to do at least 15 minutes, preferably 30 minutes, even an hour of something that is fun and makes you laugh. Because remember, laughter modulates pain. When your pain is accompanied by laughter, your brain will minimize that pain. It is one of the best ways for you to reduce pain is to watch something funny. TikTok shines as long as it's not an animal thing. Just move by those. So anyway, it was my pleasure to be your support group leader today. If you would like to get a hold of me, you can always get a hold of me, icnetwork.org. My email address is icnetwork@mac.com. It is time for me to eat. I will see you all later. Big hug. You are not alone. All right. Bye-bye. All right, Facebook. Facebook is gone. Oh, wait, no, it's not. Hold on. All right. All right, you guys on YouTube. I will see you guys later. Be well. I'll see you this week. I'll do another one this week.